Disorder and the Nutritional Management course. My name is RANEEM ALI ALMUTAIRI and I'm going to be your lecturer for the first part of this webinar. The first topic that we'll be discussing today is hypopituitarism and its appropriate nutritional management. We'll start off with some definitions and background relating to this topic. First of all, hypopituitarism is an underactive pituitary gland, and a deficiency in the production of the pituitary hormones may be caused by several factors, including tumors, trauma, radiation to the brain, stroke, or even aneurysm and surgery. So in hypopituitarism, there is a lack of one or more of these hormones and a loss of function in the affected gland or organs. Therefore, it may take years for an accurate diagnosis to be made in this case. And if all of the pituitary hormones are missing, then this is called as a panhypopituitarism, and it is considered relatively as a very rare syndrome. So, adrenocorticotropic hormones stimulate the adrenal gland to release cortisol in order to maintain the blood pressure and the blood glucose levels. And if this hormone is missing, then depression, fatigue, low blood pressure, nausea, and even diarrhea with dizziness, pale skin, weakness, and weight loss are signs and symptoms of this hormone deficiency. Therefore, a shortage of the cortisol can be life-threatening in most cases. In addition to the arginine vasopressin, which was formerly known as the antidiuretic hormone, this hormone controls water loss by the kidneys, and if it was deficient, then there is a severe thirst and excessive urination that will happen and can cause diabetes insipidus as a result. And in rare instances, a deficiency may occur after an event such as brain surgery. The symptoms of a pituitary disorder include some simple or less severe condition or signs, with others that are more severe or have a higher intensity. So this can be as light as headache or even depression, mood swings, abdominal pain and anorexia, to even infertility or cessation or irregular menses, lethargy, fatigue, loss of body hair, as well as failure in lactation or loss of sleep. Also, growth hormone deficiency, or in general, growth hormone, it regulates the somatic growth, the carbohydrate and lipid metabolism, and the adipocyte function. And there is a complex interplay between the growth hormone and insulin signaling. And if the growth hormone was deficient in children, then this will lead to short stature below 5 feet as a result. So this condition causes 10% of all cases of dwarfism. And in adults, there is an abnormal body composition with persons with this condition. Also, they have osteopenia, impaired quality of life, cardiac dysfunction, and an adverse lipid profile. And for the case of follicle-stimulating hormone and luteinizing hormone, they control the sexual functions and fertility in both males and females. And when the gonadotropin deficiency occurs, then men and women will lose interest in their sexual intercourse and can experience fatigue, weakness, loss of body hair, impotence, and loss of menstruation. So oxytocin will stimulate the uterus to contract during labor and breast to produce milk. And its mechanisms are necessary for successful pregnancies. And it is uncommon that pregnancy will develop when oxytocin levels are low. So, exploring our general background relating to this condition, prolactin stimulates the female's breast development and milk production, and its deficiency is rare but can stop milk production. And the thyroid-stimulating hormone stimulates the thyroid gland in itself to release hormones which affect the body metabolism. And when TSH is deficient, this can lead to underactive thyroid function, which is known as hypothyroidism. Symptoms of this condition include cold intolerance, constipation, weight loss, and pale and waxy or even dry skin can develop. In this case, the intervention objectives focus on replenishing any missing hormones, preventing dehydration, hypoglycemia, and related problems. Also, we focus on improving the lean muscle mass stores and monitoring the serum level of cholesterol and triglyceride, in addition to preventing vascular complications. And in regard to nutritional management, the dietary alteration that may be needed in this case, such as higher or lower energy intake, until the hormone levels are normalized. So a modified fat, cholesterol, and carbohydrate intake may be needed in order to ensure sufficient intake as well of protein. In this case, we recommend having 6 small feedings that may be better tolerated than larger ones. Also, to increase fluid intake unless it was contraindicated due to other medical condition. Also, we need to ensure they have adequate intake of all vitamins and minerals. In specific, calcium and vitamin D should be taken in sufficient amount to prevent osteoporosis from developing. Some of the common medications that are used that have potential side effects in this condition include hormone replacement therapies, such as corticosteroids, which are often used and can alter glucose, calcium, and phosphate tolerance. Also, potassium and folacin must be increased, with sodium that should be decreased. And in this case, we need to monitor for any signs of hyperglycemia. Also, thyroid preparations can be needed in this case, and having growth hormone in the shape of somatotropin requires no specific dietary intervention, and it may help in elevating the elevated triglyceride level, and having long-term growth hormone replacement therapy in adults is considered to be safe as a lifelong therapy in order to maintain the health benefits. In addition to this, estrogen, progesterone, or testosterone replacements should be monitored for any side effects that are related to heart disease and elevated levels. Also, cortisone may be needed during periods of stress or illnesses if the ACTH is deficient. And in regard to herbs potential supplement use, it shouldn't be used without discussing it first with the physician, and we should ask the patient directly if they are using any herbs or any other type of treatment that wasn't written to them by their physician. For the nutrition education and counseling, we need to have the patient to avoid long fasting and stress. Also, we should discuss the need to use small, frequent meals instead of larger ones. Also, discussing the possibility of hyperglycemia and how to manage its symptoms and avoid it from developing. And in the case of hormone replacement therapy that is usually permanent, doctor visits will need to be checked for diabetes and any signs of osteoporosis. Also, if the patient was using home tube feeding, then we need to teach them about the appropriate sanitation processes and food handling procedures. Another condition that is tightly related to thyroid disease is acromegaly. So this is a hormonal disorder that is caused by overproduction of the human growth hormone by the pituitary gland. The incident is considered to be rare, with about 50 to 70 cases per a million person in the US population alone. So the diagnosis is made common about a decade after the oversecretion of growth hormone begins. And if the growth hormone producing tumors occur during puberty, then the condition is called gigantism. So the genetics and the nutritional impact on the height of most children is unusual and can continue in their growth in the stature beyond 20s. Therefore, it should be evaluated in this case. So growth hormone can affect the growth of almost all cells and tissues and has a direct and indirect effect over the body. The direct effect of this hormone include hyperinsulinism, lipolysis, insulin resistance in the peripheral tissue, ketogenesis, hyperglycemia, and sodium water retention. So in over 98% of all cases, overproduction of growth hormone is related to benign pituitary tumors. And in few patients, acromegaly is actually caused by tumors of the pancreas, lung, or even the adrenal gland. So symptoms and signs of acromegaly include enlarged extremities with disproportionate growth of the nose, lips, brows, lower jaw, the tongue, hands, and even feet. So serious side effects include heart failure, colon polyps that becomes cancerous, and diabetes. So when we have an elevated insulin-like growth factor 1 that also occurs in acromegaly, this will result in greater protein synthesis, amino acid transportation, muscle and bone growth, DNA and RNA synthesis, in addition to cell proliferation. So high levels of growth hormone and increased IGF-1 levels, 3 to 10 times above the normal range, can be used to diagnose acromegaly. So hormones secreting pituitary tumors account for about 30% of all pituitary tumors. And having surgical removal of the pituitary gland provide about 50 to 70% chance of a cure. So acromegaly is complicated by an increased incidence of diabetes mellitus that is caused by impaired insulin sensitivity and reduced beta cell function. Also, the bones and cartilage growth can lead to arthritis, with acromegalic patients presenting with hypoadenosemia, and studies can suggest that there is a link between adipocytin, cystatin, and the fat mass with the bone changes. So premature death may result if it was left untreated, and the treatment can include surgical removal of the tumor, radiation therapy, or even injection of growth hormone blocking medication. Therefore, somatostatin analogs can have a key factor in the therapeutic plan. Also, having other receptor antagonists can competitively bind to the growth hormone receptors, therefore blocking their production and allowing for a better control in specific for the cardiac disorders and the glucose metabolism. So having improved insulin sensitivity occur after the use from a reduction in overnight endogenous glucose production. Also, somatulin depot can be used for a long-term treatment in patients who have had an adequate or inadequate response to surgery or even radiation. So the intervention objectives are to control weight, to prevent or control diabetes if it was present, in addition to hypertension or heart disease when it is present. Also prevent osteoporosis and calcium balance, which is often negative in most patients. In addition, we need to monitor for complications such as colon polyps, which may lead to cancer, as mentioned earlier. So, in addition to this, carbohydrate control diet may be needed if diabetes is present, in addition to giving the patient extra fluid intake as needed. Also, we need to control for sodium and fluid intake if there is heart failure, as well as offering sufficient intake of calcium and vitamin D with multivitamin mineral supplements that can be useful for most patients. So the common drug used and their potential side effects include promethazine, which can be taken orally to reduce growth hormone secretion. Also, side effects include gastrointestinal upset, nausea, vomiting, lightheadedness when standing, and nasal congestion. So this should be taken with food. In addition to this, octreoid injection is a synthetic form of somatostatin, and their side effects can include diarrhea, nausea, gallstones, and loose stool. So insulin may be needed if diabetes is also present, but we need to be aware of any excessive doses. Hypoglycemia can be a serious side effect in this case. So the cardiac medication can be needed, but we need to monitor for the specific side effects accordingly. And in the case of atorvastatin treatment, it is considered to be a safe, well-tolerated, and effective approach for case management. Also, pitavastatin is used to normalize the circulating level of the IGF-1 and the principal mediator of the GH action. And the somatostatin depot delivers an injection subcutaneously instead of into the muscles. So the side effects include diarrhea, cholestasis, abdominal pain, nausea, injection site reaction, and floatiness, arthralgia, and loose stool. So we need to monitor for all of these possible side effects when we are managing these cases. Also, if the patient is using herbs and potential supplement, we should encourage them to tell us about it in order to ensure that we avoid any medication interaction or any possible side effects. And for nutrition education and counseling and the care management plan, we need to discuss the body changes and altered self-image. Also, exercise can help to improve the physical functioning and the quality of life. We need to also teach the patient about the control of diabetes or heart failure when it is present. And after surgery, potential complications can include cerebrospinal fluid leaks, meningitis, and damage to the surrounding normal pituitary tissue. Therefore, it can require lifelong pituitary hormone replacement therapy. Also, if the patient was using home tube feeding, we need to teach them about the appropriate sanitation and food handling procedures. Another condition that is related to thyroid disorders is Cushing syndrome. So it is defined as a disease that is caused by an excessive cortisol, and it can be caused by an extrinsic and excessive hormonal stimulation of the adrenal cortex by tumors of the anterior pituitary. Also, it can be caused by adrenal hyperplasia or the exogenous cortisol use. So the differential diagnosis is not simple in this case, and there is no existing test that is accurate when used alone. Therefore, a focused imaging, including CT scans, MRI, and nuclear magnetic imaging, can provide a better diagnosis in this case. So the pituitary CS occurs after puberty with equal frequencies in both genders. And in adults, it has a greater frequency in women than in men. with most diagnosed between the ages 20 and 50 years of age. Therefore, the total incidence is about 10 to 15 million per a person per a year. Therefore, it is a disorder that is characterized by viralism, upper body obesity with thin arms and legs, hyperglycemia, glucosuria, and hypertension with the shape of a red moon face, and vertigo or emotional liabilities with buffalo hump or even obesity over certain areas. Also, female balding and hirsutism with blurry vision and pitting ankle edema can develop as a side effect of this condition. So in some cases, osteoporosis and severe depression are present. So the chronic cortisol hypersecretion can cause central obesity, hypertension, insulin resistance, dyslipidemia, and even prothrombotic status. So these are all considered to be manifestation of the metabolic syndrome. So there is a complex interaction between the CS and inflammation with raised level of the IL-8 and OPGs in CS patients. And despite the glucocorticoid excess, it may represent as an inflammatory and pro-atherogenic phenotype disorder. So if left untreated, it can be fatal, therefore diagnosis is not simple in this case. And having late-night salivary cortisol can be useful test in this condition, with the treatment differing according to the cause, as in the case of the ACTH-dependent type or the N-independent type or even the idiopathic type. So in the case of the atherogenic, the depletion of the steroid hormone will be needed in order to ensure for the best outcome. Also, if the pituitary gland need to be removed in some cases. So the CS caused by the ACTH production from a solid tumor can result in life-threatening hypercortisolism, and radiation, chemotherapy, or even surgery may be needed in these cases. And after the surgical removal of the adrenal gland, most of the symptoms will disappear. In addition to this, psychological impairment can persist despite a successful treatment. So the intervention objective focus on controlling the elevated blood glucose or lipid levels with managing diabetes and coronary vascular disease if they are present. Also, we need to promote weight loss if it was needed, decrease fat stores while increasing the lean body mass, as well as controlling or lowering the blood pressure when it is elevated. In addition to this, we need to prevent or control the side effects of the corticosteroid therapy with the vertebral collapse, heart failure, bone demineralization, osteoporosis, and hypokalemia. And for food and the nutritional therapy, we need to restrict sodium if steroid medication are being used, as well as using an energy-controlled diet if needed by calculating the diet according to the patient's desirable body weight. In addition to this, controlling glucose levels when they are elevated and having carbohydrate counting method that can be useful as a management approach in this case. Also, we need to ensure adequate intake of calcium and potassium, as well as ensuring adequate intake of protein if the losses are excessive. For example, if they are more than 1 gram per kg for each person. So we need to also use anti-inflammatory diet that is rich in omega-3 fatty acid, herbs, spices, and antioxidant foods. And for the common medications that are used in this case, it includes uh, with the glucocorticoid therapy, osteoporosis, and hypercalciuria are considered to be common side effects. And withdrawal of these medications after autoimmune or cancer management can cause an atherogenic CS. Also, adrenal insufficiency or steroid withdrawal symptoms can occur in this case. So having large doses of vitamin D can be necessary, but we shouldn't use it for extended periods without monitoring for toxicity. And in regard to herbs, it shouldn't be used without discussing it first with the physician, as there we should encourage the patient to disclose their use of any types of herbs. And for the nutrition education and counseling, we need to help the patient control their weight as needed. Also, we need to explain which foods are a good source of calcium in the diet, as well as explaining how to control the elevated blood sugars and lipids through having a balanced dietary intake. In addition to this, we need to manage any symptoms for metabolic syndrome through dietary changes and exercise tailored according to each patient's need and current condition. And similarly with the home tube feeding, then we need to teach the patient about the appropriate sanitation processes and their techniques. So in order for us to gain more insight into our syndromes that we'll be discussing, we need to first understand what is hyperthyroidism. Hyperthyroidism results from an oversecretion of the thyroid hormone, the triiodose, the thyroidine, or the thyroxine hormone. So these hormones affect every cell through controlling the body temperature, the heart rate, metabolism, and the production of calcitonin. So the thyroid hormone affects the glucose homeostasis through increased hepatic glucose output, as well as increased polytic cycle of the glucose degradation of the products between the skeletal muscles and the liver, therefore decreased glycogen stores in the liver and the skeletal muscles. This will also lead to altered oxidative and non-oxidative glucose metabolism with decreased active insulin output from the pancreas and increased renal insulin clearance. So when the hypothalamus signals the pituitary gland to produce TSH, this will normally regulate to be just enough in most cases. So the autoimmune thyroid disease or Graves' disease and the chronic lymphocytic thyroiditis are considered among the most common endocrine disease in childhood and adolescence. So usually in hyperthyroidism, the entire gland is overproducing thyroid hormone, and rarely a single nodule is responsible for the excess hormone secretion. So an elevated metabolic rate, tissue wasting, diaphoresis, tremor, and tachycardia with goiter or heat intolerance can be one of many signs and symptoms for this condition. So if it was left untreated, atrial fibrillation and osteoporosis can result in this case. So the thyroid test results to indicate the disease include assessing the TSH, the T4, and the T3. In the case of TSH that is high with the T4 and T3 normal, this will be interpreted as a mild subclinical hypothyroidism, where if the TSH was high and the T4 and the T3 are low to normal, then hypothyroidism is diagnosed. Where in the case of the TSH being low and the T4 and the T3 normal, this will be a mild subclinical hyperthyroidism. And if it was low with a high or normal T3 and T4 levels, this will indicate hyperthyroidism. And if they were all low, this will be diagnosed as an antithyroidal illness, which is a rare pituitary secondary hypothyroidism. So in the autoimmune thyroiditis, this may start out as a temporary disease, then will lead to hyperthyroidism. And the most common causes include hematomatous thyroiditis, a subacute granulomatous thyroiditis, or a silent lymphocytic thyroiditis. So the major environmental triggers of the autoimmune thyroiditis include iodine, medications, infection, as well as smoking and possible stress. So specific digestive disease such as celiac or primary biliary cirrhosis can as well be associated with the autoimmune thyroid process. So persons who have type 1 diabetes or even mood disorders, psychosis, or Addison disease also seems to be at a higher risk of developing autoimmune thyroiditis. Therefore, they need to be checked for having these conditions as well. Also, Graves' disease, which is diffuse toxic goiter, is the most common form of thyroid hyperthyroidism. So thyrotoxosis, which is more severe than the Graves' disease, can have clinical signs of the thyrotoxosis in Graves' disease that is caused by thyrotropin receptors stimulating the autoantibodies. So most people who develop Graves' and ophthalmopathy have one or more of the following symptoms, including dry and itchy eyes, a staring bug-eyed look, sensitivity to light, excessive tearing, or feeling of pressure around the eyes, with difficulty closing the eyes completely. Also, they may have peripheral double vision. So thyrotoxosis can alter the carbohydrate metabolism in type 2 diabetic patients to such an extent that DKA developed if it was untreated. Also, another emergency condition is the thyroid storm, or known as well as the thyroid crisis. It is a potentially life-threatening condition in which it develops in persons with hyperthyroidism. So the gland will suddenly release large amount of thyroid hormone in a short period of time. It will have signs of thyroid storm, including extreme irritability, high systolic blood pressure, and low diastolic blood pressure, as well as tachycardia, nausea, vomiting, diarrhea, high fever, confusion, and sleepiness. So shock, delirium, or shortness of breath with fatigue and coma, as well as heart failure and death can result if this condition wasn't treated immediately. So if the thyroidectomy is needed, then antithyroid agents and iodine are often given about 4 to 6 weeks before surgery to minimize the risk of a thyroid crisis. And with the thyroidectomy, the patient may require high caloric diet, high protein, respectively. In addition to this, we need to evaluate the need for post-operatively with the doctor's care plan. The intervention objective focus on achieving euthyroid state to avoid the effects of the T3 on the heart as well as the cardiovascular system by decreasing the systematic vascular resistance and increasing the resting heart rate. Also, the left ventricular contractility, the blood volume, and the cardiac output. Also, we need to prevent or treat complications accompanying high metabolic rate, including bone demineralization. So this seems to be a greater problem in older women than in adolescents. In addition, we need to focus on replenishing the glycogen stores as well as replacing the lost weight that is usually between 10 to 20 pounds. Also, we need to correct the negative nitrogen balance, replace the fluid losses from diarrhea, diaphoresis, and increased respiration. However, in the case of exophthalmos that is caused by increased accumulation of the extracellular fluid in the eyes, this may require fluid and salt restriction in specific. We also need to monitor or treat fat intolerance and steatorrhea in case it was present. And for food and nutrition, we need to use a high caloric diet, starting with 40 kilocalorie per kg, as well as the patient's caloric need that may be increased by about 50 to 60% in this condition, or even 30% in the mild cases. We also need to ensure that the patient have adequate intake of carbohydrate in particular. Also, we need to provide protein in the range of 1 to 1.75 gram per kg of the body weight, and the fluid intake should be between 3 to 4 liters per day, unless this is contraindicated by the presence of renal or cardiac problems. We also need to include about 1/4 of milk or equivalent daily to supply adequate calcium, phosphorus, and vitamin D in specific. So we need to also exclude any caffeine and stimulant from the diet because they can aggravate their excitability and their nervousness. Therefore, we need to control for their intake. And supplementation of the diet with vitamin A, C, and B complex vitamins, especially with thiamine, riboflavin, B6, and B12 is recommended, with a general multivitamin mineral supplement that can be beneficial, and we need to monitor for iodine content. Also, we need to be aware of iodine in any supplement that is used, with chronic iodine intake that is greater than 500 microgram per liter that are associated with adverse effects. So, raw natural goitrogens, including cabbage, Brussels sprout, kale, cauliflower, soybean, and peanut, shouldn't be used in the diet and should be discouraged to be used for the patient. So these substances can increase the side effect of the drugs that the patients are usually taking, but cooking them can reduce this effect. And for the common medications that are used, these include the goal of the drug therapy is to prevent the thyroid from producing excessive hormone and having anti-thyroid drugs, also called thionamide, such as the metazoles and the B2U, can cause nausea, vomiting, as well as altered state of taste sensation and gastrointestinal disorders. So these should be recommended to be taken with food and avoid using of the natural goitrogens in the raw form, but should be cooked to reduce their effect. Also, thienamides represent the treatment of choice in pregnant women, in particular during lactation, as in children and adolescents, as well as in preparation for the radioiodine therapy or the thyroidectomy. So radioactive iodine may be used to damage or destroy some of the thyroid cells, and it can cause a temporary burning sensation in the throat. Hydrochloride may be used to improve the radiation uptake in the hyperthyroid patient, as well as replacing the potassium with some drugs that can affect the thyroid glands, therefore should be monitored for specific use. And for herbs and potential supplements, using lemon balm and kelp have been recommended, but no clinical trial proved their efficacy. Therefore, they should be closely monitored, as well as we should limit the use of large quantity of iodine-rich seaweed, such as kombu. And for the nutrition education, the thyroid hormone affects the adiponectin and the adipose tissue, therefore predispositioning the patient to ketosis, and we should be aware of the hyperglycemia after a carbohydrate-rich meal. Also, we should encourage a quiet, pleasant mealtime with frequent snacks that can be needed. We will be taking a 15-minute break for Salat al-Asr and then continue our discussion. To understand and impact our later to be discussed syndrome. So first of all, hypothyroidism is caused by the underfunctioning of the thyroid gland. So it can be classified as primary thyroid failure or secondary from pituitary TSH deficiency, or as a tertiary from hypothalamic deficiency of the thyrotropin releasing hormone. Also, it can result from peripheral resistance to the action of the thyroid hormone as well. So in the primary hypothyroidism, this causes about 95% of all cases, with the most common causes of the thyroid gland failure is Hashimoto's thyroiditis. So this is an inflammation that is caused by the patient's own antibodies, as in the case of pernicious anemia or in lupus. So the second major cause of the thyroid gland failure is from various medical treatments that affect the thyroid gland, such as surgery or chronic medication use. So hypothyroidism affects up to 10% of adult women that are usually middle-aged and older women as well. And women may experience menstrual irregulations or difficulty conceiving. And in the case of the T3 and the T4 that are elevated during pregnancy with the use of oral contraceptive and estrogen use. So physicians must treat hypothyroidism to avoid long-term complications such as depression, infertility, and CVD as well. So the risk can decrease if the thyroid hormones are taken as directed with a long-term use as recommended by the physician. Also, congenital hypothyroidism or cretinism is regarded as a rare incident that is about 1 in 4,000 births. So screening for this type of hypothyroidism is now common. Also, treatment involves replacement of the thyroid hormones and the iodine, as well as it can occur in areas where the soil content of iodine is low, Therefore, fortification is recommended of the salt. So myxedema is a non-pitting edema that can occur in adults with hypothyroidism, also with the hydrophilic musculosaccharide accumulation in the skin and the muscles as well. So in the case of end-stage myxedema, untreated hypothyroidism will lead to progressive weakness, stubborn behavior, and stubborn hypothyroidemia with hypoventilation, hypoglycemia, and hyponatremia, with the development of water intoxication, shock, and even death. So this occurs most often in older patients with having underlying pulmonary and vascular disease. So thyroid autonomy is common and may contribute to miscarriage as well as to hypothyroidism development. And infants are totally dependent on the T4 levels from the mother during their first trimester for their normal neurological development. And hypothyroidism from autoimmune disease or a suboptimal iodine intake occurs in about 2.5% of pregnant women. Also, postpartum thyroid dysfunction occurs in about 5 to 9% of women's conditions. So, because of the potential problems for mothers and the babies as well, screening, diagnosis, as well as treatment of the thyroid problems among pregnant women is of utmost importance and should be monitored in all cases. And for the endemic goiter, which is an enlargement of the thyroid gland with swelling in front of the neck, that results from iodine deficiency due to inadequate dietary intake or even due to medication impact. So over 3 billion people in the world are on iodine supplementation program in order to ensure the best thyroid function. So optimal levels of iodine intake to prevent thyroid disease is in a relatively narrow range around the recommended daily iodine intake of 150 micrograms. So the subclinical hypothyroidism is considered to be a mild thyroid failure and is diagnosed when the peripheral thyroid hormone levels are within the normal reference laboratory range, but the serum TSH levels are mildly elevated. So iodine, iron, selenium, and zinc deficiency can all impair the thyroid function. So iron deficiency impairs the thyroid hormone synthesis by reducing the activity of heme-dependent thyroid peroxidase, as well as the iron supplementation that may improve the efficiency of iodine supplementation. Therefore, should be recommended for use. So anemia is considered another major manifestation in hypothyroidism, and not only because of the impaired hemoglobin synthesis, but also because of the iron deficiency from increased iron losses with menorrhage, as well as impaired intestinal absorption of the iron folate deficiency due to impaired intestinal absorption of folic acid and pernicious anemia with vitamin B12 deficiency. So selenium deficiency and the disturbed thyroid hormone status can develop in the case of phenylketonuria, as well as in cystic fibrosis and from poor nutrition in children or in elderly people or sick patients. So in parts of the world where iodine and selenium are both deficient, a dual supplementation can be advisable in this condition. So anemia, which is a major manifestation of the hypothyroidism, is not only developed because of the impaired hemoglobin synthesis, but also due to the iron deficiency from the increased iron losses with the menorrhage. Also due to the impaired intestinal absorption of iron, of folate deficiency due to impaired intestinal absorption of the folic acid, and of that of the bare mucus anemia with vitamin B12 deficiency. So selenium deficiency and the disturbed thyroid hormone status can develop in the case of phenylketonuria or cystic fibrosis, as well as from poor nutrition in children and in elderly people or sick patients. Also, in parts of the world where iodine and selenium are both deficient, a dual supplementation can be advisable. So, symptoms of hypothyroidism by life stages are different. For example, during infancy, symptoms range from constipation, cyanosis, developmental delay, horse's cry, marked retardation of the bone maturation, persistent jaundice, poor feeding, respiratory difficulty, somnolence, and umbilical hernia. Where in children, this can range from evidence of mental retardation, poor performances at school, retarded growth, as well as stunning or short stature. Where in adults, this can include abnormal menstrual cycles, brittle nails, broad flat nose, coarse features with dry hair or cold intolerance as well, with even decreased libido, delayed dentition, and difficulty in losing weight, as well as hair loss and a range of other symptoms. So vitamin A deficiency and the iodine deficiency disorders can affect up to 30% of the global population. And these deficiencies often coexist in the vulnerable groups. Also, given alone without iodine repletion, high-dose vitamin A supplementation in combined VAD and ID may reduce the thyroid hyperstimulation as well as reducing the risk for goiter. So, more research on vitamins and mineral therapies will be beneficial in this condition. And for the intervention objective, we need to control the weight gain that results from about 15 to 40% slower metabolic rate, especially in the untreated patients. Also, measuring the weight frequently to detect fluid losses or retention is recommended as well. We also need to correct any underlying causes such as inadequate intake of iodine or congenital deficiency and having hormone replacement therapy that will be given. So we need to correct vitamin B12 and folic acid as well as iron deficiency anemia when it is present. We also need, because of the vitamin D that has implication in the autoimmune disorder, we need to assure an adequate diet and supplementary sources are given as needed for these patients. Also, for the intervention objective, we need to improve the energy level and reduce the fatigue. And we need to improve the cardiac, neurologic, and renal functions, as well as screening for the thyroid problems in pregnant or postpartum women. And we need to assure hormone replacement as needed. Also, for food and nutrition, we need to use an energy controlled diet that is adjusted according to age, gender, and height. We also need to have a multivitamin mineral supplement formula that can be beneficial, especially to replace nutrients that have been poorly absorbed. So, since the TSH3 or the T3 is an important hormone needed for vitamin A metabolism, then the serum levels may be low in this population. So, including good source of carotenoids such as lycopene is recommended in this condition. Also, we need to ensure that the patient has adequate supply of antioxidant and fiber-rich food as well as fluid. We also, for pregnant women or children, we need to make sure that adequate amount of iodine are consumed on a daily basis. Also, for the natural goitrogens in cabbage, turnips, rapeseed, peanuts, and cauliflower, or even broccoli, uh, these may block the uptake of iodine and the body cells that are inactivated by heating and cooking. Therefore, we need to ensure that they are properly cooked before we are or the patient is consuming them. Also, we need to achieve optimal iodine intake from the iodized salt in the range of 150 up to 250 grams per day for adults. This is to minimize the thyroid dysfunction. Also, zinc, copper, and tyrosine are needed as supplementation in these populations. We also need to ensure adequate iodine status during prenatal parenteral nutrition, particularly in the case of preterm infants. And for the common drugs that are used and their potential side effects, in the case of thyroid hormones, such as sodium levothyroxine and synthroid that are used, we need to use them with caution with the use of soy protein products since they can decrease the effectiveness of the hormones. So thyroid hormones elevates the glucose and decreases the cholesterol level. Therefore, we should monitor the persons who have diabetes carefully. We also should monitor for weight changes and fluid shift, and if there was a rapid weight loss, sweating, or other symptoms of hyperthyroidism that develops. So the doctor should be contacted for immediate follow-up. Also, lithium treatment for bipolar disorders has been associated with the development of goiter, and we need to monitor the patient closely. And for herbs and potential supplements, it shouldn't be used without discussing it first with a physician, but we should avoid kelp tablets and thyroid support supplements, as these can lead to gentian or can include gentian walnut, mustard, radish, and other types of herbs that have been recommended, but there are no clinical trials to support their use. Also, curcumin and vitamin A, B12, B3, and E can be beneficial, but longer trials or studies are needed to ensure that they are actually effective and don't have any side effects. Also, if larger quantities of iodine-rich seaweed, such as kombu, are consumed, then we need to their use should be monitored in patients who take thyroid medications and replacement hormone therapy. And for the nutrition education and care management, we need to discuss the use of goitrogens in cabbage and in vegetables, including turnip, rapeseed, peanuts, cassava, and soybeans, as they are inactivated by heating and cooking. Also, we should encourage the use of iodized salt as permitted, and we need to avoid self-medication with iodine supplements. We should also encourage the use of adequate fluid intake, and women who are considering pregnancy may want to have or be screened to rule out any thyroid problems. And if their iodine intake is low, or if they live in an area without the use of iodized salt, then they may need an iodine supplement prescribed from their physician. So a normal urinary iodine level would be between 150 up to 250 and should therefore be monitored carefully. So in many developing countries, children are considered to be at a higher risk for iodine deficiency. Also, they are at risk of VAD deficiency as well as iron and deficiency that will lead to anemia. So we need to select the appropriate supplementation in this case after identifying which ones they need. Also, because of the subclinical hypothyroidism that is common in individuals who have chronic kidney disease, we should monitor closely the glomerular filtration rate that is recommended. In addition to this, we need to have exposure to large doses of metals such as lead and mycobodium or arsenic that may reduce the thyroid function. Therefore, we should monitor or assess if the patient have exposure to these metals. So this will lead to adverse effect on the development, on behavior, as well as on the reproduction of the pregnancies and production of children. Also, if the patient was using home tube feeding, we need to teach them about appropriate sanitation processes and food handling procedures. Another important topic to explore is the parathyroid glands in order to understand how they implicate the syndrome that we are discussing. So the parathyroid glands have an overall regulatory role with the actions as a thermostat in the systematic calcium homeostasis to ensure tight regulation of serum calcium concentration and appropriate skeletal mineralization. So the parathyroid hormone affects the calcium, phosphorus, and vitamin D metabolism by removing calcium from bones to raise the serum level. It also promotes hydroxylation of vitamin D to its active form. So calcitonin, in contrast to the parathyroid hormone, decreases the serum calcium levels as it is secreted by the thyroid gland. So the body secretes the BTH in response to hypocalcemia or hypomagnesemia, with the hormone then stimulating osteoclasts to increase the bone resorption. So the BTH also stimulates adenine cyclase to increase renal tubular calcium resorption and the phosphate excretion. Therefore, the BTH works with vitamin D to regulate the total body calcium by activating the conversion of vitamin D to its active form. So the active form will stimulate calcium and phosphate absorption from the GI tract. So calcitonin, in contrast to the BTH, decreases the serum calcium level and is secreted by the thyroid gland. So the fibroblast growth factor 23 is a hormone which regulates the minerals and vitamin D metabolism. And researchers researches on the effect of the various genes and the hormones in the bone homeostasis is still ongoing in order to ensure that we have the best recommendations for patient best health outcome. So hypothyroidism and hypocalcemia are related, as hypothyroidism results from deficiency of the parathyroid hormone from a biologically ineffective hormone, or this could be due to damage or accidental removal of the glands, or even due to impaired skeletal or renal response. So in the hereditary form, the parathyroid gland are either absent or not functioning as well as it should be. So symptoms appear before the age 10. Other causes include magnesium deficiency or neonatal immaturity. And if this was left untreated, then hypoparathyroidism, retardation dysmorphism can result in this case. So cancer response in the hypoparathyroidism is abnormal, suggesting that parathyroid hormone is required to maintain normal trabecular structure. So hypoparathyroidism with hypocalcemia is one of the most common results of damage to the parathyroid gland during surgery. So in fact, it may also be diagnosed during a workup for hypocalcemia. And vitamin D levels may also be deficient in this condition, and having intraoperative parathyroid hormone levels that are used widely during the parathyroidectomy as an indicator of parathyroid gland function. So vitamin D supplementation after surgery may be given to anticipate a decreased parathyroid gland function to avoid any symptomatic hypocalcemia from developing. So hypoparathyroidism is considered as a chronic condition that require lifelong treatment with large doses of calcium and vitamin D supplements. So episodes of tetany are treated with calcium that is given intravenously to provide quick relief of the symptoms. Also, controlled release of the physiological concentration of the parathyroid hormone can be achieved using a surgically implemented controlled release delivery system. And for the intervention objectives, we need to normalize the serum and the urinary levels of calcium, phosphorus, and vitamin D as well. We should also prevent long-term complications such as cataract, pernicious anemia, Parkinson's disease, as well as any other related bone disease. Also, we need to prevent mental retardation or malformed teeth in the affected children, as we should treat the disease as early as possible. Also, we should decrease the symptoms of tetany and improve the overall health status of the patient. So using high calcium diet with dairy products, nuts, salmon, peanut butter, broccoli, and other green leafy vegetables is recommended. So if this is tolerated, then lactose should be included in the diet for better calcium absorption. Also, we should give the patient oral supplements that are high in calcium, such as calcium carbonate, in order to ensure that the patient have the most optimum levels. We should also reduce the excessive use of meat, potatoes, and oxalic acid, such as spinach, chard, and rubber. So if the diet contains a large amount, then we should reduce their intake. Also, intake of vitamin D and protein should be adequate, at least to meet the recommended levels for their intake. And for the common medications that are used, this can include calcium lactate, as it can be used in a dose between 8 to 12 grams. Also, calciferol, which is vitamin D analog, is used with calcium supplement in this condition. Also, the calciferol rolosterol can also be useful and should be recommended in some cases. In addition, diuretics sometimes are given to prevent too much calcium from being lost through the urine, which is a problem that can lead to kidney stones. So taking diuretics also reduces the amount of calcium and vitamin D supplements that are needed. And overuse of steroid may cause hypocalcemia, therefore should be monitored carefully to avoid their presence. And for herbs and potential supplements, it shouldn't be used without discussing it first with the physician. Therefore, we should ask the patient directly if they are using any type of these supplementations. For the nutrition education and counseling, we should indicate which foods are good sources of calcium, phosphorus, and vitamin D. We should also indicate which foods are considered as sources of phytate and therefore should be avoided. Also, we should discuss the role of sunlight exposure in vitamin D formation and how it relates to the individual need and how it can be utilized for the best outcome. And if the patient was using home tube feeding, then we should teach them on appropriate sanitation processes and food handling procedures. First of all, the primary hyperthyroidism results from parathyroid adenoma in up to 80% of the cases. So hyperplasia of the parathyroid gland in about 10 to 20% of the cases, or cancer can develop. So double parathyroid adenoma can occur in about 2 to 15% of the cases, and the BPH has been associated with premature death in CVD and therefore should be quickly managed according to its diagnosis. So in cases of secondary hyperthyroidism, it occurs in renal failure or even after renal transplantation. So calcium deficiency and phosphorus retention are involved in the pathogenesis of this condition. So parathyroid gland hyperplasia develop in the asthmatic patient, producing hypercalcemia as well as hyperphosphatemia. And in the secondary hyperparathyroidism in cases of chronic disease, it is stimulated by dietary phosphate loading and ameliorated by the dietary phosphate restriction. So the disorder is complex in that not enough phosphate is cleared from the body, and phosphate is released from the bones, and vitamin D is not produced. So thereafter, the absorption of calcium in the gut is low, and the serum levels of calcium are lowered as well. While in children with renal failure, their growth can be impaired. So postmenopausal women, after having gastric bypass surgery, they may show evidence of secondary hyperparathyroidism with elevated bone reabsorption. So there is an effect of early breast tumors on the calcium homeostasis, and subclinical hyperparathyroidism may increase the risk for breast cancer. So the age-induced or increased parathyroid plasma levels have been associated with cognitive decline and dementia. And having increased parathyroid hormone levels may become as a biological marker of both dementia as well as osteoporosis. So parathyroidectomy can include or induce long-lasting improvement in the regulation of blood pressure, in the left ventricular diastolic function, and other signs of the myocardial ischemia. This will lead to improved life expectancy in general in these patients' populations. So a minimally invasive procedure is available for these conditions. Also, after surgery, having mild cognitive changes seems to improve, specifically for depression and anxiety. And the intervention objective in this case focus on lowering the elevated serum calcium and the urinary calcium levels, as well as maintaining the calcium levels between 8.4 and 9.5 milligram per deciliter. So elevation of constipation, anorexia, weight loss, and weaknesses is recommended as a first management objective. Also, avoiding clinical consequences such as renal osteodystrophy, hyperphosphatemia, cardiovascular calcification, also extraskeletal calcification, endocrine disturbances, neurobehavioral changes, and compromised immune system with altered erythrobiosis, renal stone, and sleep disturbance can all occur, therefore should be managed appropriately according to each condition. So preventing rickets and growth delay in children should be a primary objective as well. And preparing for surgery if parathyroidectomy is necessary by ensuring that the patients have the optimal lab results and the best health outcome before the surgery is initiated. So for food and nutrition, using a low calcium diet with pure dairy products, including nuts, salmon, peanut butter, and green leafy vegetables is recommended. Also, extra fluid is useful to correct or to even prevent dehydration, which can elevate the serum calcium level. We should also limit the phosphorus containing food if hyperphosphatemia is present. In addition to this, using alternatives such as non-dairy creamer, sorbet, jams, and jellies with white rice, noodles, and even with migraines, cream cheese, and whipped cream or pretzels, if there was extra calories that are needed in order to ensure that the patient consume all of their recommended daily intake of calories. Also, the dietary protein should be 0.8 gram per kg to have a balanced intake of protein in adults in order to ensure the most optimum outcome for these patients. So for the common medications that are used, this includes vitamin D therapy that sends a signal to the parathyroid gland to slow down the making of the parathyroid hormone. So this helps in preventing many of the unwanted complications of the hyperparathyroidism. So the phosphorus facts include having a normal VO4 levels in the plasma, which is between 2.5 and 4.5, and the total VO4 levels should be between 500 to 700 grams, and about 80% or 85% of this should be in the bones. And for the dietary reference intake, this should be 700 milligram per day, and the typical US dietary intake is about 1,200 milligram, which means over than the recommended intake. So the GI absorption mainly is passive through the NADI transporter and is enhanced by vitamin D intake. So the kidney, considered as a major regulator for this, that is mediated by brush borders of the transporter. And the parathyroid hormone increases the excretion and vitamin D decreases the excretion, and therefore these mechanisms should be monitored for their optimum outcome. And in regard to the phosphorus-rich food, there are the dairy products such as milk, cheese, and yogurt, where there is as well the dried beans and lentils, including kidney beans and soya beans, also the black-eyed beans. In addition, it can be present in nuts and seeds, such as almond, cashews, and sunflower seeds, and in meats in high quantities, such as liver, organ meats, and sweetbreads, with sardines and herrings as well. It can also be present in other food items, such as bran flakes, wheat grams, chocolate, and soft drink. And some of the common medications that are used and their potential side effects include the treatment with the active vitamin D from their analogs that can increase the VDR expression. So this will inhibit the growth of the parathyroid tumors and reduce the parathyroid hormone levels. Also, some examples of vitamin D analogs can be used, and these products are especially useful for the dialysis in the case of renal failure patients. Also, nuts, which has been approved to treat the HPT in renal patients and the parathyroid cancer. It can also appear to be effective in treating the parathyroid calcium, normalizes the serum calcium with only modest increase in the parathyroid hormone levels. So, phosphate binding agents that don't contain calcium offer a therapeutic alternative for managing renal osteodystrophy. Also, some other medications, Civilmar, lowers the serum phosphorus and the parathyroid hormone levels without inducing hypercalcemia. So it binds with the drugs such as fumaricide or the cyclosporine, making them less effective, therefore should be monitored effectively. And the timing of the administration should allow several hours between these medications to avoid any interaction. Also, standard protocols are recommended for the use of the phosphate binders and should be followed when they are administered. So, once yearly intramuscular calcitrophil injections have been used to correct vitamin D deficiency, and controlled trials are needed to determine the effect on the parathyroid hormone levels over time. And some antacids can contain high levels of calcium and therefore should be monitored carefully. Also, biphosphonates may be needed to decrease the risk of osteoporosis in some cases. And for herbs and essential supplements, it shouldn't be used without discussing it first with the physician, but conjugated linoleic acid can reduce the prostaglandin E synthesis, which is required for parathyroid hormone release. But more research is needed in this area to ensure for the most optimal outcome when these supplements are being used. And for the nutrition education, counseling, and care management, we should discuss food that are sources of calcium, phosphorus, and vitamin D, the indicated food sources of phytate and oxalate, and if the intake is a concern, therefore should be monitored carefully. Also, we should discuss the role of sunlight exposure in vitamin D formation and how it can relate to the individual needs. And we should advise the patient to drink plenty of fluid for the best outcome in all of these cases. And in case of renal patients, we should have a focused counseling that may help to clarify the misunderstanding of the simple dietary facts. And the doctor should monitor calcium and phosphorus monthly and the parathyroid level on a quarterly basis. Also, exercise and smoking cessation may be needed in order to ensure the best outcome in all of these conditions. And for food-borne illnesses education, if the patient was using home tube feeding, we should teach them on the appropriate sanitation processes and food handling procedures. Another condition that is related to thyroid disorder is the metabolic syndrome. So the metabolic syndrome is defined as insulin resistance syndrome or syndrome X. So it has simultaneous clustering of the low levels of HDL cholesterol, hyperglycemia, high waist circumference, hypertension, as well as elevated triglyceride level. So the presence of any three of the following 5 criteria constitute the diagnosis of a metabolic syndrome. So elevated waist circumference of about 40-inch or 102 centimeters in men, or 35 or 88 centimeters in women can constitute metabolic syndrome. Also, elevated triglyceride level of more than 150 milligram or drug treatment for elevated triglyceride levels. In addition to reduced HDL cholesterol level to less than 40 in men and 50 in women, or having a medication treatment for low HDL cholesterol levels. In addition to this, elevated blood pressure of more than 130 in the systolic blood pressure, or 85 diastolic blood pressure, or having medications to manage high blood pressure. In addition to this, elevated fasting glucose of more than 100 milligram or drug treatment for elevated glucose levels can constitute the presence of the metabolic syndrome. So the presence of any three of these syndrome is considered as a diagnosis for metabolic syndrome. So metabolic syndrome is associated with CVD and often lead to type 2 diabetes. And this condition affects some young people, but usually affects persons who are over the age 55. And more than 64 million Americans have metabolic syndrome, roughly 1 in every 4 adults, and about 40% of adults who are over the age 40 and older. So increased birth weight, excessive energy intake, physical inactivity, obesity, smoking, inflammation, and hypertension can all be considered as contributing factors to the development of metabolic syndrome. So individuals who are obese and insulin resistant as well are particularly prone to this syndrome. And having an oven-shaped figure with a high waist circumference is considered to be riskier because of the fat cells that are located in the abdomen that will release fat into the blood more easily than the fat cells that are found elsewhere. So the serum adiponectin levels are associated with insulin sensitivity, and they are decreased in type 2 diabetes and in obesity. So genetic and environmental factors that contribute to the risk are considered also contributing factors, with the initial insult in the adipose inflammation and insulin resistance that is perpetuated through the chemokine secretion. Also, the adipose retention of the macrophage and the elaboration of the pro-inflammatory adipocytokines. So, in women, depressive symptoms are associated with the metabolic syndrome, especially with the elevated afternoon and evening cortisol levels. So, clearly, more research is needed in this area to ensure the best outcome for the patient condition. So, management of the metabolic syndrome focus on lifestyle modification, especially reducing caloric intake and increasing physical activity. So, the phytochemicals, monounsaturated fatty acids, antioxidant foods, spices such as turmeric, cumin, and cinnamon all have anti-inflammatory effects and therefore should be monitored for their intake. In addition to this, intake of whole milk, yogurt, calcium, and magnesium protect against the metabolic syndrome, whereas intake of cheese, low-fat milk products, and phosphorus doesn't. Therefore, should be avoided. So the intervention objectives focus on reducing the inflammatory state and insulin resistance that is caused by excessive adipose tissue. So improved body weight, it reduces the abdominal obesity in particular, with a realistic goal for weight reduction that should be between 7 to 10% over a 6 to 12-month period. Also, we should promote physical activity, and the recommendations should include practical, regular, and moderate regimen of exercise with a daily minimum of about 30 to 60 minutes and equal balance between aerobic and strength training. So achieving and maintaining the cholesterol, blood glucose, and blood pressure levels at the indicated levels by the American Heart Association is as the following. For the atherogenic dyslipidemia, the elevated LDL cholesterol level, we should give a priority to the reduction of the LDL cholesterol over the other lipid parameters. So to achieve the LDL cholesterol goals based on the patient risk categories, LDL cholesterol for the different risk categories are as the following. For example, in the high risk, we should seek a level between 70 to 100, where for the moderate risk, moderately high risk, we should seek a level between 100 and 130. And for the moderate risk, we should seek a level of 130, where for the lower risk, about 160 milligram per deciliter is considered to be as an acceptable range. So if the triglyceride level is more than 200, then goal for the non-HDL cholesterol for each risk category is about 30 milligram per deciliter higher. So if the triglyceride is more than 200 after achieving the LDL cholesterol goal, we should consider additional therapies to attain the non-HDL cholesterol goals. And if the HDL cholesterol is less than 40 milligram per deciliter in men or less than 50 milligram in women, then having a raised HDL cholesterol to the extent possible with the standard therapies for both the atherogenic dyslipidemia as well as with either lifestyle therapy that can be intensified or the drug therapy that can be used for raising the HDL cholesterol level depending on the patient's specific risk category. While in the case of elevated blood pressure, we should reduce the blood pressure at least to achieve a blood pressure of more than 140 over 90 or less than 130 over 80 if the patient is diabetic. So reducing blood pressure further to the extent possible through lifestyle changes is also recommended. And if the patient has a blood pressure over 120 over 80, then we should initiate or maintain lifestyle modification through weight control, increased physical activity, sodium reduction, and emphasis on increased consumption of fresh fruit, vegetables, and low-fat dairy products in all patients who have the METS. So for blood pressure that is over 140 over 90, or if the patient is diabetic, we should add blood pressure medication as needed to achieve the blood glucose, the blood pressure goals according to the patient condition. And if the patient had an elevated glucose level for the IFG, we should delay the progression to type 2 diabetes by encouraging the patient to have weight reduction and increase their physical activity to the most appropriate extent that they can. As well as for the hemoglobin A1C levels at or above 7%, then lifestyle therapy and pharmacotherapy is recommended. And if necessary, it should be used, and therefore we should modify for other risk factors and behaviors such as abdominal obesity, physical inactivity, elevated blood pressure, or any other lipid abnormalities that are present. And for the prothrombotic state, we should reduce the prothrombotic, the thrombotic and the fibrinolytic risk factors with having low-dose aspirin therapy or prophylaxis that is recommended for these patients' use. Also, for the pro-inflammatory state, there are no specific therapies beyond the lifestyle changes for this condition, but having antioxidants and omega-3 fatty acid can be helpful and specific for these conditions. And for food and the nutrition, the general recommendation include having low intake of saturated fat, trans fat, and cholesterol, with increasing the use of omega-3 polyunsaturated fatty acid intake, as well as the monounsaturated fatty acid, in specific the extra virgin olive oil, and planning a Mediterranean type diet using more fiber and starches, especially whole grains, raw fruit, and vegetables, with a plant-based diet that may be useful. So DASH diet contain about 3 to 4 grams of sodium with a good source of potassium, calcium, and magnesium. And having dairy products can provide calcium, magnesium, and potassium as an additional source. So monitoring the blood glucose level and the carbohydrate restriction has been shown to improve the dyslipidemia that are associated with the metabolic syndrome more than only following a low-fat diet. Therefore, this should be recommended in most cases. We should also encourage the soy protein as a meat substitute several times a week, as the soy proteins can be helpful with weight reduction and dyslipidemia in some patients. We should also encourage the patient to have adequate intake of folate, as well as vitamin B6, B12, vitamin C, E, and preferably they should consume it from food sources rather from supplementation, as this can bring a more healthy, balanced diet approach for the patient. We should also encourage the patient to have dark chocolate in small amounts regularly. That can be helpful in lowering the blood pressure, improving cholesterol, and can help as well with the insulin sensitivity in order to improve the glucose absorption in general. In addition, we should spread out the energy load by eating smaller, more frequent meals throughout the day. This is recommended over large, smaller meals or larger meals taking at a spread interval in general. So smaller, more frequent meals is the recommended approach in this condition. Also, the common medications that are used and their potential side effects include to lower the lipid. Therefore, a statin should be used initially unless this is contraindicated due to the presence of some other condition. Also, statins can decrease the biomarkers of inflammation and oxidative stress in a term of a dose-related manner, and having atorvastatin about 80 milligram compared with a 10 milligram dose is superior for decreasing the oxidized LDL level, as well as the CRP matrix and other tumor necrosis factors activity. So having a glucose-lowering medication must be carefully prescribed and monitored for each patient, and metformin may be indicated in these cases. In addition to this, blood pressure medications can be prescribed. Therefore, monitoring for the necessary restriction of sodium or higher need for potassium is required. And having ACE inhibitors or an angiotensin receptor blocker is usually the first medicine of choice. And some medications that diminish the insulin resistance and directly alter the lipoproteins are necessary, with combination therapy that is often required in most cases as the most appropriate approach to manage these complicated conditions. So if the patient with metabolic syndrome have an elevated fibrinogen and other coagulation factors leading to prothrombotic status, then aspirin is used as a management step. And having low-dose aspirin is not generally a problem, but it should be taken with meals or light snack to prevent the potential side effects of GI bleeding. And for herbs and potential supplements, antioxidant supplements are not recommended in this condition. but the intake of antioxidant-rich food should be suggested. Also, thus far, trials with alpha tocopherols have been disappointing, but further trials with gamma and alpha tocopherols are warranted in order to ensure that the patients have the best outcome for these cases. In addition, we should include phytochemicals, antioxidant food, and spices such as turmeric, cumin, and cinnamon in the diet. And chromium biphenolate enhances the insulin's action by lowering the plasma membrane cholesterol level. And CoQ10 may have some merit, but further research is needed to indicate its appropriate action or role in these conditions. In addition to this, having a high selenium concentration have been associated with prevalence of higher FBG, LDL, triglyceride, and glycated hemoglobin levels, but further research is also needed to determine its role in the development or even the progression of the metabolic syndrome. In addition, other herbs and potential supplements shouldn't be used without discussing it first with the physician to ensure the most optimum outcome for these patients' health. And for nutrition education, counseling, and care management, widespread screening is recommended to slow the growth of this syndrome. Also, prevention should start in childhood with healthy nutrition, daily physical activity, and annual measurement of weight, height, and blood pressure beginning at the age of 3 years. We should also discuss the role of nutrition, DASH or Mediterranean diet principles in managing this syndrome. In addition to obesity, that is a major contributor to the problem, so weight loss in about 10 pounds can help improve the health status, even if it was a little amount that is lost. So a diet that is rich in antioxidants and DASH diet is considered beneficial. And finally, according to the dietary guidelines that are consistent with lowering the risk of metabolic syndrome, therefore should be followed. In addition to this, having regular physical activity can help to lower the elevated blood cholesterol level as well as blood pressure. And walking or an exercise that is pleasant for the individual is the one to select so to be sustainable and also to have the best outcome in general. So aerobic and strength training exercise are beneficial as well and should be followed whenever possible if the patient can't do it. And having reduced sedentary activities, including television and computer time, is also recommended to ensure the best outcome for the patient health. And smoking cessation measures may be needed for this condition. We should also offer guidance on how not to gain weight after quitting and how to maintain their guidelines and their cessation after they have stopped. And for patient education in foodborne illnesses, if the patient was using home tube feeding, we should teach them about appropriate sanitation and food handling procedures. So an important complication that is present in most of thyroid disorder is osteoporosis. And the nutritional management for this case include, first of all, discussing the osteoporosis disease in general. As we know that bone density usually declines with age, as the peak instant of the bone density is between the ages of 20 up to 40, and then there is accelerated loss that begins during menopause in females and gradual loss during elderly age. So as the person gets older, their bone density declines and they are at a more higher risk of having osteoporosis. So bone density is also was found to be related to race, as Black males were found to be at a higher risk to have a bone decline, but they have a higher bone density to begin with, while white females have a lower bone density and will have the highest decline in their bone density. So osteoporosis have different types. There is first the primary osteoporosis. This is the juvenile type that begins between the ages of 8 to 14 and is regarded to be as a rare condition, genoidal dysfunction with bone pain and fracture that can develop in this process. Also, type 1 primary osteoporosis occurs between the ages of 50 to 65 years, which is regarded as the postmenopausal osteoporosis. It is characterized by a phase of accelerated bone loss, and this bone loss occurs primarily from a trabecular bone and fracture of the forearm, as well as the wrist and the vertebral bodies that is common in this age group. Where in type 2 osteoporosis, this occurs between the ages over 70 and older and is regarded as an age-related condition. So in this type, the fractures occur in the cortical and trabecular bones. And in addition to this, the wrist and the vertebral fracture, the hip fractures are common in this age group and usually very high in their incidence. Where in the case of the secondary osteoporosis, this can be related to the genetic, gonadal, endocrine, or inflammatory or deficiency status, or even due to medication use. So in case of genetics, this can be related to cystic fibrosis, to even erythrodermals, the hematochromatosis, other syndromes such as Marfan syndrome, porphyria, osteogenesis imperfecta, homocystinuria, or due to idiopathic hypercalciuria and Gaucher disease. While in the gonadal secondary type, this can be related to androgen insufficiency, also female athlete syndrome, hypercalcitonemia, and hypothyroidism. Also, it can be related to anorexia nervosa and bulimia nervosa. Where in the endocrine type, this can be related to acromegaly, adrenal insufficiency, Cushing syndrome, diabetes, hyperparathyroidism and hyperthyroidism, or even estrogen deficiency and pregnancy. Also, in the inflammatory association type, this is related to IBD, also some other conditions such as rheumatoid arthritis, systematic lupus, chronic liver disease, or metabolic acidosis and osteoporosis. And for the deficiency status, this can lead to calcium deficiency, magnesium deficiency, as well as protein, vitamin D, or celiac disease, or even malabsorption syndromes. Where in the drug-induced type, this can be caused by anticonvulsant medication, antipsychotic, antiretroviral, aromatase inhibitors, prednisone, lithium, or other medication for thyroid disease. Also, other conditions that can cause the secondary osteoporosis include lymphoma, multiple myelomas, leukemia, and hemophilia. In addition to thalassemia and sickle cell disease or metastatic disease, and multiple sclerosis or alcoholism and chronic renal failure. So all of these conditions can be associated with the incidence of the secondary osteoporosis. For the diagnosis of osteoporosis, this can be done by having the bone density scan, which is referred to as the DEXA scan. Also, DEXA result can be like this, in which we can interpret whether the patient have a declined bone density or not. And according to the age, fracture risk, and the T-score, it was found that people aged over 75 will have a higher T-score for fracture risk, while those aged 55 will have somewhat of a less score, and those under 35 years will have the least score for having fractures that are due to osteoporosis. So the T-score range will depend whether it is normal, then the result will be higher than 1, where osteopenia, the result will be between 1 and 2.5, and in the case of osteoporosis, the result will be 2.5 or lower. So the T-score and the bone density, the higher the T-score is, then this will mean that the person or the patient have a normal bone density, while if they have a score of the T-score between -1 and -2.5, this will indicate a low bone mass, while a result that is less than 2.5, -2.5, will indicate the presence of osteoporosis, and therefore appropriate management is initiated immediately. So after the mid-30s, the person begins to slowly lose bone mass, and women lose bone mass faster after menopause, but it can happen to men as well. So in the early ages, before 30s, the person will have an active growth with a higher bone density, but after 30, this will have a slow loss that will represent a rapid loss between the ages of 50 to 60, and then they will have a less of a rapid loss, but rather their fracture risk will depend on the bone density they had previously. So the T-score, actual bone density, is represented for women between 0 to 0.95 in most cases. This is at the age of 25, and then this begins to decline to up to the age 85. So some cross labs of the CT scans indicate that over 90% of the organic matrix of the bone is regarded as type 1 collagen, and the DBD is excreted and unmetabolized in the urine and is unaffected by the diet. So making it suitable for assessing for the resorption and the bone density in general. And in the case of a mature bone, the DBD crosses the links, provide rigidity for indicating the appropriate score that is present. So how does the TTX is performed? So this second void morning urine sample that is sampled between 10 a.m. is the collected sample in order to be analyzed and tested for the bone frequency. So what is the result? Means that for females, 3 to 7.4, and for male, the result is 2.3 up to 5.5 as a normal range for their bone density to be present. And management in these cases include assessing the bone cycle of resorption, reversal, formation, and then resting to ensure for the best outcome in the bone density in a manner that is representative. So the basics of bone health include assessing calcium, vitamin D, having regular exercise, preventing falls in elderly, and having good nutrition in addition to stopping smoking or smoking cessation. So following these steps will ensure that the patient will have their optimal bone density when they are older. So diet basics for the key points in order for sugars. We should have high intakes that is related to high urinary calcium loss. Therefore, this should be reduced. And the refined grains and flour, this will equal about 60% of calcium and 85% of magnesium losses by retraining the process. Also, caffeine, a high intake related to higher urinary calcium loss, and alcohol will lead to osteoporosis that is common in the chronic alcoholics, but other factors will play as well. And for protein, high intake related to higher urinary calcium losses, and having fizzy drinks or soft drinks will be phosphoric acid intake that is linked to bone losses. Therefore, this should be reduced as much as possible. So for protein, it is considered as essential for the muscles function, as well as the muscle function is essential for the bone health. So this is a reversible process in order to ensure that we have the optimum bone density and health. So we should keep the dietary ratio at 3 to 1 to produce protein, and in order to ensure the best outcome in these conditions. And for calcium, the recommended calcium intake for children between the ages of 7 to 12 is 800 milligrams. This is also the same for teenage girls between 11 to 18, but for teenage boys in the same age range, this should be 1000 milligrams. Also, for men having between the ages of 20 to 60, they should have 700 milligrams per day. And women should, over the age 60, sorry, for men, they should have 1,500 as well. And for women, the intake between the ages 20 to over 60 is also 700 and is the same for pregnant women and shouldn't be increased. But when they are breastfeeding, they should have 700 milligrams plus another 500 during their pregnancy trimesters. So calcium in the diet, for example, in sesame seeds, this will represent about 670 milligrams of calcium intake. Also, tofu have about 500 milligrams of calcium content, and cooked spinach, for example, will have a reduced intake of about 160 milligrams. So cooking food will reduce the intake, the content of calcium in the item. Therefore, this should be consumed preferably raw and uncooked. in order to ensure that it has the most appropriate or the highest amount of calcium. Also, fried wheat bait can have high content of calcium, and Edam cheese, cheddar cheese, as well as sardine or fish in general can have a higher content of calcium. Therefore, they are recommended to be consumed at least once every week. So common calcium consideration includes assessing the type of the calcium that we are consuming, also the intake levels that we are consuming and whether this food was cooked or not, in addition to the age and gender, as well as the level of gastric acidity, the use of PPI, also calcium deposition issues, and drug interactions such as antibiotic use, and high or even low blood calcium levels to begin with, which can indicate the presence of endocrine disease in most cases, therefore should be monitored carefully. Also, calcium is associated with heart disease and therefore should be assessed accordingly. So 30% increase in the incidence of myocardial infarction was found to be at patients who have a lower calcium content. So a BMG study looked at about 15 clinical trials where the calcium was taken as monotherapy, and the data obtained from studies relating to calcium and osteoporosis, not calcium and heart disease only. Another study found a 6% decrease in the cardiovascular related death. This was a double-blinded trial of about 1,200 milligram of calcium taking for 5 years. They found a non-significant 6% decrease in the cardiovascular disease-related death, and therefore indicated that there is association between calcium and cardiovascular disease. Also, vitamin D was found to be associated with osteoporosis, in particular for thyroid disease. As 1 microgram of vitamin D, which is equivalent to 40 international units, should be consumed as to give us the most optimum bone density. And vitamin D intake, according to the Food Standard Agency, for guidance purposes, a level of about 1,000 international units should be consumed for the intake of vitamin D. That wouldn't be expected to cause any adverse effects in the general population, but rather will lead to the most optimum health outcomes in general. So vitamin D synthesis begins when we have exposure to the sunlight. This will penetrate the skin in an inactive form and then converted in the liver to the active form of vitamin D and in the kidneys as well. So normal vitamin D levels for the UK unit measured in millimole and the US in nanograms. It should be about 25 nanomoles, then defined as a deficient intake, but we should always test for vitamin D active form, its presence in these populations to ensure that they have the best outcome. So recent studies have indicated that about 85% of those with levels less than 50 nanomoles had good response to biphosphate therapy. Therefore, aiming to have a higher value of 75 will lead to better results in general in order to ensure that the patients have the most optimum therapy for their osteoporosis and its management. So common vitamin D consideration should include the patient's origin, whether they are Asian and they are at a higher risk of vitamin D deficiency. Also, do they avoid the sun, living in northern latitude? Do they avoid meat intake or oily fish intake? Also, the type of vitamin D present or the most commonly present in their population. So vitamin D, the active and the inactive form, are structurally similar, but their differences include that vitamin D, which is the calcium, is made in the body, but vitamin D2 is not made in the body or produced in the land, plants, or animals. Also, vitamin D3 is naturally derived supplement from wool grays from the sheeps, but vitamin D2 is produced from yeast, fungus, and synthetic derived supplements. Also significantly increased vitamin D levels in the body with vitamin D3, but vitamin D2 doesn't increase its body content to that high compared to vitamin D3. In addition, recommended for optimal bone health is D3, but vitamin D2 is an alternative form that is appropriate for strict vegetarians or vegan diets to be consuming. So the dietary vitamin D sources can include cod liver, and 1 tablespoon can give us about 1,300 international units. Also, salmon can give us a high content, and mackerel and tuna, as well as beef liver, large eggs, and Swiss cheese, all of which are sources that are high in their content of vitamin D and are regarded as appropriate dietary supplementary sources. In addition, vitamin K was found to be related to osteoporosis as well, and there are different vitamin K types. These include vitamin K1, which is called as phytoiodine. It is present in plants, including spinach, Swiss chard, cabbage, kale, as well as cauliflower and broccoli sprout. Where vitamin K2 is called methionine, which is present in the gut and the fermentation process increases, as well as the natto presence. Also, vitamin K3, which is the menadine, is a synthetic form for vitamin K, as well as vitamin K4, which is the menadol, is as well as a synthetic form for vitamin K. So some key points for vitamin K include having low K1 levels that are commonly found in patients with osteoporotic fractures, as well as vitamin K is known to promote bone mineralization, and that is taking alongside with vitamin D can significantly reduce bone losses. So increased osteocalcitonin production can develop with vitamin K. In addition to that, we should encourage blood clotting. So care with anticoagulant is recommended when the patient is consuming vitamin K or when they have some sort of blood clotting disease. Also, antibiotics that are over 10 days of use can reduce vitamin K because of the effects on the gut flora. Therefore, we should monitor closely if the patient was using antibiotic and give them supplementation of vitamin K when needed. So the dietary vitamin K1 can be present in foods such as cooked curly kale, spinach, turnip, broccoli, Brussels sprouts, raw parsley, and cooked okra in general. Also, trace minerals has been found to some trace minerals have been found to affect osteoporosis development and as well as the bone density. So the boron and strontium have been found to be associated with osteoporosis. For borons, its supplement in about 3 milligram can reduce the urinary excretion of calcium and magnesium. Also, it can have effects on calcium and magnesium, possibly via regulating estrogen and testosterone levels. Also, it is found in almonds as well as hazelnuts, Brussels nuts, and as well as dried apricot, avocado, dates, and especially high in content in raisins. While for strontium and its own implications, diet normally delivers about 1 to 3 milligram per day and can have significant amount that is lost in fluid refining. In addition, it is known to stimulate bone formation and can inhibit its loss. So having high intake associated with thyroid and pituitary dysfunction was found to be relating to this condition and naturally found in spinach as well as in lettuce, carrots, peas, beans, potatoes, and celery, as well as grains such as wheat, barley, and in different amounts depending on the soil that they are grown in. And of course, any uncooked food will have a higher content than that of the cooked ones. Therefore, these should be taken into consideration when we recommend the dietary management for patients with osteoporosis in general. We'll be taking a 15-minute break until we continue our webinar. Thank you for your time.
Iodine deficiency. For many individuals, iodine deficiency goiter is only a cosmetic problem. In some, however, particularly older adults, the goiter may be large enough to cause compression of the trachea or esophagus or delay recognition of coexisting thyroid cancer. The role of iodine intake in thyroid cancer is still controversial. The incidence of thyroid cancer has increased in the last decade. However, this increase does not appear to be influenced by the usual range of iodine intake from dietary source, although increases in iodine intake may change the distribution of subtypes of thyroid cancer. Correction of iodine deficiency in many countries has shown an increase in papillary thyroid cancer over anaplastic and follicular thyroid cancer. Thus, by reducing these more aggressive subtypes of thyroid cancer, iodine prophylaxis program may be contributing to the decrease in thyroid cancer mortality. Let's move now and talk about the relation of iodine and hyperthyroidism. Iodine deficiency increased the incidence of diffuse and nodular goiter. Over time, autonomous growth and function may also result in toxic goiter and hyperthyroidism if iodine deficiency is not extremely severe. In regions of mild to moderate iodine deficiency, toxic multinodular goiter is a common cause of hyperthyroidism in older adults. Hyperthyroidism more likely to develop if iodine intake is supplemented, just as it can occur in patients with non-toxic nodular goiter living in iodine replete region who are given large doses of iodine. Let's talk about another entity, which is hypothyroid. Hypothyroidism, due to very low iodine intake, is now extremely rare. Adults have typical clinical manifestations of hypothyroidism and usually a goiter. So by this, I conclude the first part of the presentation, and I will go further now to the next part. So before I go further with some of important items related to the common thyroid diseases, I like you to have an idea or to have understand the most common thyroid diseases in the clinical practice. Um, I invite all of you to join a Twitter account, scientific Twitter account, IndoDMOS. Actually, is at its scientific Twitter account about endocrinology and diabetes. If you are interested in this field, you can follow our account. It's about the update, quick review, guidelines, drugs related basics in the field of diabetes and endocrinology. So please, if you are interested, join our Twitter account, IndoDMOS. EEAN, sorry, DODMOS. Now I will talk about the hyperthyroidism. I will talk in this topic about these items: definition, epidemiology, causes, clinical presentation, laboratory diagnosis, and management. And in the definition of hyperthyroidism, as you know, is a hypermetabolic state resulting from excess thyroid hormone. It is more common in female than in men. Overall prevalence approximately 1.3% increase to 4 to 5 in older female. Also more common in smoker. Graves' disease mostly in younger women. Toxic nodular goiter more in older women. You have to know that the hyperthyroidism depends on the underlying cause, and therapy depends on the underlying cause. From a pathogenetic viewpoint, hyperthyroidism results from two mechanisms which can be distinguished using 24-hour radioactive iodine uptake. A very important point is to deal with radioactive or uptake scanning. It is very critical to determine the uptake scan of every patient because it will give you a clear we can say diagnosis. If there is uptake scan in the whole gland, it means we are dealing with something related to autoimmune hyperthyroidism, which is definitely under the terminology of Graves' disease. But if we are talking about the uptake in particular, can say a point or in particular nodule, either here in this case you are dealing with toxic nodule if there is one hyperfunctioning nodule, or if we have a multiple toxic nodular goiter, if there are multiple increase in the uptake scanning all over the gland. So a very important point, if you are talking about the hyperthyroidism, please concentrate or focus on the uptake scan. It is very important. Sometimes a patient with hyperthyroidism comes to you with low uptake scan. And this is, again, a very important point. In such a case, it means we are dealing with thyroiditis. It means patient here is having a transient hyperthyroidism, a phase of thyroiditis, and definitely by this way you will deal with treatment in a different way, because we know the thyroiditis maybe need only symptomatic treatment and no need for further treatment with antithyroid medication. So again, please, if you are dealing with any patient with hyperthyroidism, a very important diagnostic test is to go with uptake scanning. Here, as you see in this picture, the uptake scanning is increased all over the gland. It means we are dealing with Graves' disease, because the overall uptake is in the whole gland. Sometimes it is not seen, or only we are seeing nodules or multiple nodules. It means we are dealing with we can say toxic nodular goiter or toxic multinodular goiter. Let's move now further and talk about the hyperthyroidism. Hyperthyroidism can be classified into number one, hyperthyroidism with normal or high radioiodine uptake. It indicates de novo synthesis of hormone treated by methimazole, thionamide, which interfere with hormone synthesis. Hyperthyroidism with near absent radioiodine uptake indicate inflammation or destruction of thyroid issue with release of preformed hormones into circulation or extrathyroidal space. So as you see here, near absent or low uptake means we are talking about thyroiditis. But if we have a real hyperthyroidism, it means the uptake will be seen either in the whole gland or as nodules. Thyroid hormone is not being actively synthesized as a result. Thionamide is not a useful treatment in this case. If we are talking about the first category, which is hyperthyroidism with normal or high radioiodine uptake, number one differential diagnosis is autoimmune thyroid disease. And we have here differential diagnosis. Number one differential is Graves' disease. And the second one is Hashimoto's. And the second item here is autonomous thyroid tissue. And we have differential including toxic adenoma, toxic multinodular goiter. Number three, TSH-mediated hyperthyroidism, TSH-producing pituitary adenoma, non-neoplastic TSH-mediating hyperthyroidism, human chorionic gonadotropin mediated, like Habermas's gravidarum and trophoblastic disease. If we are talking about the low uptake scan, the first differential is thyroiditis, as we mentioned, and we have many subcategory like subacute granulomatous equivalent thyroiditis and painless thyroiditis, silent thyroiditis, lymphocytic thyroiditis, postpartum thyroiditis. Amiodarone also may cause iodine-induced hyperthyroidism and radiation thyroiditis, with palpation thyroiditis as well. What about exogenous thyroid hormone intake? We include excessive replacement therapy, intentional suppressive therapy, factitious hyperthyroidism, and finally ectopic hyperthyroidism, including the metastatic follicular thyroid cancer and stroma ovarian ovarian tumors. This is the clinical picture of Graves' disease, in which we are seeing the patient with, we can say, typical thyroid orbitopathy. And as I told you before, the normal uptake is seen here. And if there is increase in overall uptake, it means we are dealing with Graves' disease. Toxic multinodular goiter in uptake appears like this photo. We have multiple nodules in the right and left side with high uptake. Toxic adenoma, only one nodule with high uptake is seen. Clinical manifestations of hyperthyroidism. We know that many symptoms appears in the patient. For example, weight loss, increased appetite, irritability, tremor, heat intolerance, vomiting, diarrhea, gynecomastia, sweating, and definitely eye complaints, especially in patients with Graves' disease. But in cases of signs, or if we are talking about, signs, maybe we can observe tremor, hyperkinesis, tachycardia with atrial fibrillation, full pulse, warm, vasodilated peripherous, systolic hypertension, cardiac failure, lead lag, staring, edema in the conjunctiva, ophthalmoplegia, periorbital edema, goiter, bruit, and weight loss. Proximal myopathy, proximal muscle wasting also observed in these cases. Overview of the clinical manifestation of hyperthyroidism in adult. Graves' disease, the most common cause of hyperthyroidism. Graves ophthalmopathy, infiltrative dermopathy, localized or peritibial myxedema, diffuse goiter, or all can be seen, available in less common causes of hyperthyroidism, such as painless thyroiditis, TSH secreting pituitary tumor. What about the Graves triad? If you are seeing these three manifestations, including hyperthyroidism, thyroid enlargement, goiter, ophthalmopathy, and dermopathy may be present. The first one is almost in all of the cases, and the goiter as well. Ophthalmopathy is seen in 36%. If it is there, exophthalmos is always present. What about the skin manifestation? Usually patients comes with warm, rarely erythematous due to increased blood flow, smooth decrease in keratin layer, sweating increase in the calorogenesis, heat intolerance, vitiligo, alopecia areata, thyroid acrobacy, commonly present with asymptomatic clubbing. There are some skin manifestations, including infiltrative dermopathy, only in patients with Graves' disease and peritibial myxedema, onycholysis, loosening of the nail from the nail bed, plumber nail, and softening of the nails also can be seen. And also some other clinical manifestations related to the hair, like thinning of the hair. So these are the signs also observed in the hyperthyroidism gravis. Lid lag is evaluated, and this is clear in this patient as you observed in the video. Lid lag is evaluated by having the patient follow the examiner's finger as it is moved up and down. Only Graves' disease have ophthalmopathy, inflammation of extraocular muscles and orbital fat, and connective tissue, which result in proptosis, exophthalmos, impairment of eye muscles function, and periorbital and conjunctival edema. Ophthalmopathy is more common in patients who smoke cigarettes. Also, if you see the sclera down between the iris of the eye and the lower lid, it means you are dealing with exophthalmopathy, exophthalmos case or proptosis case. Ophthalmopathy, gritty feeling or pain in the eyes, may have diplopia due to extraocular muscle dysfunction, corneal ulceration as a result of proptosis and lid retraction. Severe proptosis can cause optic neuropathy and even blindness. Lid retraction is observed if you see the sclera above the iris, as you see here clearly in this photo. What about the manifestation of cardiovascular system in hyperthyroidism? The cardiac output both due to both increased peripheral oxygen need and increased cardiac contractility. Heart rate is increased, pulse pressure is widened, and peripheral vascular resistance is decreased. Systolic hypertension is common, high or normal output congestive heart failure. Maybe in some patients with severe hyperthyroidism, atrial fibrillation can be seen with irregular pulses in the clinical finding of physical examination. What about the others manifestations? Hyperglycemia, dyspnea, weight loss due to increased metabolic rate, hypermetabolism, and secondarily to increased gut motility associated with hyperdefecation and malabsorption. Amenorrhea, thyroid hormone stimulate bone resorption, resulting in reduced volume of bone. The net effect is osteoporosis and an increased fracture risk, and hypercalcemia, psychosis, agitation, depression, anxiety, restlessness, irritability, and insomnia also can be observed. If we are talking about the hyperthyroidism diagnosis in the clinical lab, maybe T3 will be high, T3 toxicosis variant of Graves. If hyperthyroidism is suspected, recommend the following lab. Number 1, TSH initially. If subnormal, go for free T4 and FT3. If TSH is low and if T4 and T3 are high, confirm, look for differential diagnosis. As we mentioned before, the uptake scan is very important. T3 toxicosis variant in which we are seeing high T3 only or more increase in T3 in proportion to T4. If T3 and if T4 high, but TSH is normal or high. Pituitary MRI sometimes is important to be seen with cases of TSH secreting adenoma. If TSH is low and T3, but not if T4 is high, mostly differential diagnosis is Graves' disease or autoimmune functioning thyroid adenoma. However, the possibility of exogenous T3 ingestion should also be considered. Patient without overt signs of hyperthyroidism in the setting of low serum TSH and normal free T4 and T3 most likely have subclinical hyperthyroidism. What about antibodies summaries? Usually, anti-TSH receptor antibodies in up to 95% of the cases of Graves' disease will be positive. Anti-TG between 50 to 70%, anti-TBO 50 to 80%. What about autoimmune thyroiditis? Anti-TSH receptor seen in 10 to 20%, anti-TG between 80 to 90, anti-TBO between 90 and 100% of autoimmune thyroiditis. Let's talk about the treatment of Graves. It is autoimmune disorder resulting from TSH receptor antibodies, also called thyroid stimulating immunoglobulin, stimulate thyroid gland growth and thyroid hormone synthesis and release. Factors associated with its occurrence include a positive family history, the presence of other autoimmune conditions, recent severe stressors, tobacco use, possible viral exposures, associated with other autoimmune diseases like polyglandular syndrome. So the treatment here, you have to focus on 3 main lines. Number 1, antithyroid drugs. Number 2, giving radioactive iodine ablation therapy. And number 3, thyroid surgery. Adrenergic symptoms treated by beta blocker, thyroid surgery for concurrent suspicious nodules, extremely larger goit, ophthalmopathy also, in which we are preferring to go with such a case like surgery. If we talk about anti-thyroid drugs used either as short-term to control the hyperthyroidism in preparation for thyroidectomy, or longer period, 6 to 18 months, in attempt to achieve disease remission, propylthyroxine and methimazole are the two antithyroidal drugs available because of presumed immunomodularity effect. Anti-thyroid medications or drugs result in drug-free remission rate between 30 to 50% in patients with Graves' disease who are treated for 1 year. Very important points to be considered about the antithyroid. Don't use thionamide in patients with baseline absolute neutrophilic count less than 1,000 or elevated transaminase of the liver, especially if more than 5 folds. A reversible cholestatic pattern on liver function can be seen with carbimazole. Drugs rash occur in 2%. Severe hepatic necrosis has predominantly with BTU. BTU should not be used as a first line except in the first trimester of pregnancy, during which methimazole have been associated with possible teratogenicity. Let's move to radioactive iodine ablation. Usually it ablates over active thyroid in 90% of the cases, characteristically after a single dose. If thyrotoxicosis still persists after 6 months, repeat the dose. Although some patients become euthyroid, the expected outcome is hypothyroidism, at which time thyroid hormone replacement is begun. It is associated with worsening of Graves' ophthalmopathy, at least transiently. In severe Graves' ophthalmopathy, not recommended. In mild to moderate eye disease, consider prophylactic prednisolone. If radioactive iodine treatment is selected, isolation precaution should be applied. What about the toxic adenoma and toxic multinodular goiter? It results of focal plus minus diffuse hyperplasia of thyroid follicular cells, activating somatic mutation of genes identified. Examination usually reveals palpable nodule or nodules over all the gland enlargement. Obstructive symptoms occur if the gland is large, especially if associated with substernal extension. Thyroid scan, toxic adenoma, solitary overactive hot nodule, or a toxic multinodular goiter like a patchy uptake of the radioiodine with increased uptake in autonomous region and reduced uptake outside those areas. Antithyroid drugs can achieve drug-free remission in Graves' disease, but only modulate thyroid hormone production in toxic multinodular goiter and toxic adenoma. It is required continuously. The radioiodine active is the definitive treatment. So, if you have toxic adenoma case or multinodular goiter with hyperfunctioning, the definitive treatment is usually the radioactive iodine. But you can use the ablation, you can go for antithyroid use to control symptoms in the beginning. Surgical options include remove involved loop in toxic adenoma, total thyroidectomy in toxic multinodular goiter. In total thyroidectomy, use lifelong levothyroxine. Hyperthyroidism with a near absent radioiodine intake, as we mentioned, it is due to thyroid inflammation, leading to release of preformed hormones, exogenous ingestion of thyroid hormones, ectopic production of thyroid hormones. In thyroiditis, this is a very common symptoms or entity. You will find hyperthyroidism in the first 3 months, followed by hypothyroidism, and then by normal thyroid function. Inflammation of thyroid tissue with transient hyperthyroidism due to release of preformed hormones from the colloidal space. The initial presentation is followed by hypothyroid phase and then recovery of thyroid function. Subacute thyroiditis, subacute granulomatous thyroiditis, it is called Diquevan thyroiditis, which is a viral or post-viral syndrome characterized by fever, malaise, and painful and tender goiter. The painless thyroiditis, it is called also silent thyroiditis or subacute lymphocytic thyroiditis, part of spectrum of autoimmune thyroid disease and occur in the postpartum period. What other causes of thyroiditis? We have destructive thyroiditis, in which we are seeing direct chemical toxicity with inflammation, amiodarone or sunitinib, radiation thyroiditis, external radiation or after radioiodine therapy, drugs that interfere with immune system, interferon alpha, palpation thyroiditis, example including during parathyroid surgery. What is the treatment? As we mentioned before, beta blocker for symptomatic control and anti-inflammatory like non-steroidal anti-inflammatory drugs. In severe cases, maybe we can use the prednisolone. What about the exogenous or ectopic hyperthyroidism? It resulting from excess thyroid hormone originating from outside the thyroid gland and can arise from external or internal source of excess thyroid hormone. It includes factitious ingestion of thyroid hormone, acute hyperthyroidism from T4 overdose, treated by beta blocker drugs which block 5-mono deiodinase such as ibudate and severe cases plasmapheresis or dialysis. Finally, subclinical hyperthyroidism in which we are seeing low TSH, normal T4 and T3 with mild or asymptomatic patient. Thyroid uptake scan consistent with underlying cause. Uptake will be high in Graves' disease or nodular goiter. Treat when TSH level is less than 0.1 or in patient with symptoms. Antithyroid drugs as first step to normalize TSH. More definitive therapy can be pursued later if a positive response is observed. I am done with my topic, and just a reminder for all of you, if you are interested about diabetes and endocrine field, please follow our Twitter account ENDOMOS, ENDOMOS. It's a pure scientific account about endocrinology and diabetes. Please, if you have an interest, follow our Twitter account. Maybe it's the time now to go for a break for the Maghrib prayer. So please, let's go for the break about 15 minutes, and we will back, inshallah, at 7 to continue the webinar. Thanks. So as we talked before, or as we mentioned before, there are many relations or a lot of association between the diet and thyroid diseases. And we elaborated and explained all of the association in the literature on the articles. And we'll focus, I will continue to focus on the most important the thyroid diseases, which has, we can say, association with diet. And we mentioned before about Graves' disease And now the time to go further and talk about the multinodular goiter. This is just a icebreaker. So the epidemiology of hyperthyroidism is related to iodine, as you see here in this photo or in this, you can say, map. Some countries are associated with severe iodine deficiency. These countries also a degree of public health significance of iodine nutrition based on median urinary iodine. As we mentioned before, some diseases related to iodine deficiency, some related to more iodine intake, and we have countries with moderate iodine deficiency, and we have mild iodine deficiency with optimal also iodine deficiency countries, and there are risk of adverse health consequences observed also, risk of iodine-induced hyperthyroidism in some countries. So the distribution among the world is different. So that's why we are seeing some variation in thyroid diseases among the populations. Hyperthyroidism is more common in female, as we know, and 5 to 1% is the distribution or the prevalence. Sorry. Try to share my slides again. 1 second. Sorry. So the usually even the as we mentioned before, the subclinical hyperthyroidism, in which we have mild symptoms like, for example, increased rate of atrial ectopy and threefold increased risk of atrial fibrillation. 60% of hyperthyroidism patients with atrial fibrillation with rhythm convert spontaneously to sinus rhythm when the hyperthyroidism is treated. In one study, all who spontaneously converted did so within 4 months after becoming euthyroid. Among those who do not convert spontaneously to sinus rhythm and who undergo successful electrical cardioversion, the 2-year risk of recurrent atrial fibrillation was 59%, compared with 83% of patients whose atrial fibrillation was not associated with hyperthyroidism. The role of anticoagulant is controversial, but very important as a clinical practitioner or healthcare provider, that you have to know that there is indication to give anticoagulant therapy for patients with hyperthyroidism and atrial fibrillation. Please, one of important indication to prescribe anticoagulant to prevent any clots formation related to atrial fibrillation is the atrial fibrillation associated with the hyperthyroidism. Left atrial enlargement, which is risk factor for thrombus formation or clot formation, is present in about 90% of hyperthyroid patients with atrial fibrillation cases, and 2% of hyperthyroidism patients with sinus rhythm as well. Based on these results, usually anticoagulant is advised. What about other manifestations related to hyperthyroidism? Serum lipid, also we can observe patients with hyperthyroidism tend to have low serum total and high density lipoprotein, low total cholesterol, HDL cholesterol ratio also observed. What about the hyperglycemia? Although thyroxine is not a counter-regulatory hormone, hyperthyroidism can interfere with glucose metabolism. It is associated with increased sensitivity of pancreatic beta cell function to glucose, resulting in increased insulin secretion and antagonism to peripheral action of insulin. The latter effect usually predominate, leading to impaired glucose tolerance in untreated patients. Adrenal function. Interpretation of cortisol response to ACTH stimulation testing may be misleading in patients with hyperthyroidism because cortisol binding globulin levels decrease, resulting in lower total serum cortisol concentration. It is observed in one of the reports of 49 hyperthyroid patients undergo ACTH testing. 35% had subnormal total serum cortisol less than 18 microgram per deciliter, while only 11% had subnormal free cortisol index as well. Respiratory symptoms, including dyspnea or dyspnea on exertion, may occur for many reasons in hyperthyroidism. Oxygen consumption and CO2 production increase. These changes result in hypoxemia and hypercapnia, respectively, both of which stimulate the ventilation. Respiratory muscles weakness is an important cause of dyspnea, and reduced exercise capacity may be larger due to respiratory muscle weakness and decreased lung volume. There may be tracheal obstruction from a large goiter. Hyperthyroidism may exacerbate underlying asthma. Pulmonary arterial systolic pressure is increased. What about the GIT symptoms? Weight loss is due to primarily to increased metabolic rate, hypermetabolism, and secondarily to increased gut motility and associated with hyperdefecation and malabsorption. Rare patient with staturia. Celiac disease is also more prevalent in patients with Graves' disease. Most patients have hyperphagia, but an occasional patients with mild hyperthyroidism may have sufficient appetite to stimulate that weight is gain, more commonly seen in younger patients. Anorexia may be prominent in elderly hyperthyroid patients. Other changes that may occur include vomiting, abdominal pain, rarely, dysphagia due to goiter, abnormalities in liver function test, particularly high serum alkaline phosphatase concentration, and rarely cholestasis. What about the hematological finding? Red blood cell mass is increased in hyperthyroidism, but the plasma volume is increased more, resulting in anormochromic normocytic anemia. Serum ferritin concentration may be high as well. Graves' hyperthyroidism may be associated with autoimmune hematological disorder such as idiopathic thrombocytopenic purpura and pernicious anemia, and some patients have anti-neutrophil antibodies. Hyperthyroidism may also be prothrombotic. As an example, in one small study of thyroid cancer, patients taking levothyroxine in doses causing mild hyperthyroidism, level of fibrinogen, prothrombin fragments, protein S, antithrombin were significantly higher than in euthyroid control. Overt hyperthyroidism patients have increased von Willebrand factor and shortened in vitro platelets plaque formation time, indicating enhanced platelets function. Let's move and talk about genitourinary symptoms. Urinary frequency and nocturia are more common in hyperthyroidism, although the mechanism is uncertain. Possible causes include primary polydipsia and hypercalciuria. Enuresis is common in children. In women, serum sex hormone binding globulin concentration are high, which result in high serum estradiol concentration, a low normal serum-free unbound estradiol concentration, high serum LH, and reduced mid-cycle surge in LH secretion. oligomenorrhea, and anovulatory infertility also observed. Amenorrhea can occur in women with severe hyperthyroidism. In men with increased serum 6 hormone binding globulin results in high serum total testosterone concentration, but the serum free unbound testosterone is low or normal. Serum LH concentration may be slightly high. Extragonadal conversion of testosterone to estradiol is increased. So that serum estradiol is high. These changes can cause gynecomastia, reduced libido, and erectile dysfunction. Spermatogenesis is often decreased or abnormal. For example, more spermatozoa are abnormal or non-motile. Thyroid hormone stimulate bone resorption, resulting in increased porosity of cortisol bone and reduced volume of trabecular bone. The loss in cortical bone density is greater than that of trabecular bone. Serum alkaline phosphatase and osteocalcine concentration are high, indicative of increased bone turnover. The increase in bone resorption may lead to an increase in serum calcium concentration, therapy inhibiting parathyroid hormone secretion, and conversion of calcidiol 25-hydroxy vitamin D. In addition, the metabolic clearance rate of calcitriol is increased. These changes can result in impaired calcium absorption and in an increase in urinary calcium excretion. The net effect is osteoporosis and increased fracture risk in patients with chronic hyperthyroidism. The neuropsychiatric manifestation, including patients with thyrotoxicosis, may experience behavioral and personality changes like psychosis, agitation, depression, less overt manifestation that more common in less severe thyrotoxicosis include anxiety, restlessness, irritability, and emotional liability. Insomnia, also common. Symptoms often worsen in patients with pre-existing psychiatric disorder. These behavioral manifestations are accompanied by cognitive impairment, particularly impaired concentration, confusion, poor orientation, and immediate recall, amnesia, and constructional difficulties. What about geriatric hyperthyroidism? It is manifested with apathia. Patient will be like hypothyroid patient, less active, rather than having hyperactivity, tremor, and other symptoms of sympathetic overactivity. However, 2/3 of such patients have symptoms similar to those in younger patients. In cross-sectional studies of patients with hyperthyroidism, older patients had a reduced risk of presence of severe classical symptoms, heat intolerance, tremor, nervousness, but a higher prevalence of weight loss and shortness of breath compared with younger patients. Older population also had a higher rate of atrial fibrillation and moderate to severe ophthalmopathy. Elderly patients with Graves' hyperthyroidism are less likely to have goiter. Toxic multinodular goiter is more common in elderly, although the majority of hyperthyroidism patients at any age have Graves' patients at any age have Graves' hyperthyroidism. In addition, elderly patients often have persistent constipation. Tachycardia 100 beats per minute is absent in 40% of elderly hyperthyroidism patients due to primarily to coexistent conduction system disorder. Hyperthyroidism in elderly patients may be apathic, as we mentioned before. 2/3 of such patients have symptoms similar to those in younger patients. In cross-sectional studies of patients with hyperthyroidism, older patients had a reduced risk of presence of several classic symptoms like heat intolerance, tremor, nervousness, higher prevalence of weight loss, shortness of breath compared with younger patients. Older patients also had a high rate of atrial fibrillation. Sorry. Now it's the time to move further and talk about the how to differentiate in lab. As we mentioned before, we have many differentiation, including differential diagnosis, Graves' disease, toxic adenoma, toxic multinodular goiter, maybe subacute thyroiditis with thyrotoxicosis phase, postpartum thyroiditis, exogenous use of T4, exogenous use of T3, TSH secreting pituitary tumor. So in all of these, you can observe low TSH, except if there is exogenous T3, you will find high TSH, and TSH pituitary tumor also normal or high. What about the FT4 concentration, normal or high in all of these? FT3 normal or high in all of these. Antibodies, as we mentioned before, including anti-TBO, anti-TG, anti-TSH receptors, according to the underlying cause, which will be plus minus, but usually we know the anti-TSH receptor antibodies will be positively, strongly positive in patients with Graves' disease. Radio uptake also with high uptake seen in all of Graves, toxic adenoma, toxic multinodular goiter will be normal or will be low. In cases of like, for example, thyroiditis. We'll give quick hints about toxic adenoma before we conclude. Toxic multinodular goiter and toxic adenoma frequently result from somatic mutation in G alpha subunit or TSH receptor causing constitutive activation in one or more nodules, which lead to autonomy of function and secondary thyrotoxicosis. Recent exposure to iodine should be determined because acute iodine lead either in the diet or intravenous from medical testing can lead to iodine-induced thyrotoxicosis. This is again one of the important associations, especially if patient has pre-existing thyroid autonomy. And this is called Joule-Risotto phenomena. Physical examination may reveal one or more palpable nodules, and overall gland enlargement. Patient can be asymptomatic or exhibit classic signs of thyrotoxicosis. Obstructive symptoms can occur if the gland is large, especially if there is any significant substernal extension. With toxic adenoma, the thyroid scan will reveal a solitary overactive, or it is called hot nodule with separation of the non-autonomous extranodular tissue. In contrast with toxic multinodular goiter, a thyroid scan will reveal a patchy uptake of radioactive iodine with increased uptake in autonomous region and reduced uptake outside those areas in areas of decreased uptake, determining if the reduced uptake correlate with normal appearing tissue or distinct thyroid cold nodule is essential because the latter requires a specific evaluation, including aspiration. What about the role of ultrasonography useful in assessing toxic multinodular goiter? Because scan finding can be correlated with normal thyroid architecture, and functional nodules can be delineated from non-functional one. Iodinated contrast should be avoided in patients with toxic thyroid nodules if possible, and close monitoring by thyroid function test is indicated. Anti-thyroid drugs can achieve drug-free remission in Graves' disease, as we mentioned before, but the definitive treatment of a toxic nodular goiter is the ablation. By this, I conclude my topic here, and it's the time now for anybody to have any comment in the chat box, any questions. So we have 2 minutes to discuss your points, if any. So please, if you have any point to be clarified or any question need further evaluation or further discussion, please let me know in the chat box. Looks like no points related to the topics. And for the other points here, maybe the organizing, the organizers will take care. So thanks again for your listening. I hope it was interesting for all of you. Hope to see you soon in another course or in another webinar with another topics, inshallah. By this, I conclude my topics and hope to see you soon. Assalamu alaikum wa rahmatullah. I think I will leave the mic now to my colleague, Dr. Hamid. Assalamu.
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Bandar. Thank you. I want to thank all audience today with us with the disorder of the thyroid disease. And I want to thank also Virtual Medical Academy for preparing and preparing this course. I will talk about thyroid disorder in form of the hypothyroid, as we see. Disorder hypothyroidism is a form of thyroid disease characterized by slowing of the thyroid function. It's a common disease nowadays involving male and female. Mainly in female patients, there are a lot of patients they are complaining of thyroid disease because hypothyroidism is secondary to autoimmune thyroid disease or post-surgical, which is nowadays is very common procedure, thyroidectomy, followed by hypothyroid due to removal of the thyroid tissue. So the diagnosis of primary hypothyroidism is characterized by high serum thyroid stimulating hormone and low serum free thyroxine concentration. Clinical feature, usually it's a slow process, slowing of the metabolic process, slowing of the accumulation of the matrix substance and others. So the mechanism of the slowing of the metabolic process symptom, fatigability, weakness, dyspnea, and congestive heart failure, cognitive dysfunction, mental retardation, and constipation. And sign will see the patient, they have slow movement, delay relaxation of the tendon of the reflexes, and bradycardia. And there is accumulation of the matrix, the patient complaining of dry skin, hoarseness of voice, and edema. And in the examination, patient shown puffy face, loss of eyeballs, and peripheral edema, enlargement of the tongue. And there is other feature of the hypothyroidism, decreasing of the hair, hearing, and myalgia, paresthesia, depression, menorrhagia, and irregular menses. And there are also some patients complaining of pubertal delay. And there is diastolic hypertension, pleural effusion, ascites, and galacturia. So this is the picture show the face of the hypothyroid patient. It's usually puffy face. There is some patient associated with the enlargement of the thyroid. It's called goiter. And the patient complaining of muscle weakness and also dry skin. There is also slow the heart rate. Patient can complain of the bradycardia, dizziness, and there is constipation called slowing the movement of the bowel. And also the patient female, they have menorrhagia, a lot of vaginal bleeding, and muscle weakness, joint pain, and delay of the tendon reflexes. And also most common feature of these patients, they are gaining weight because accumulation of extracellular fluid. So diagnosis by doing the thyroid function test, the patient had high thyroid stimulation hormone and low free T4. Major causes of hypothyroidism is usually, as I said, is autoimmune disease, autoimmune thyroiditis. And the second most common cause of hypothyroidism is atherogenic after thyroidectomy or radioactive iodine therapy of the thyroid thyrotoxicosis. Iodine deficiency or iodine excess, it can cause hypo or hyperthyroidism. Drugs like thionylamide, lithium, amiodarone can cause hypothyroidism. There is transient hypothyroidism, venous thyroiditis, subacute thyroiditis, post-infectious thyroiditis, and there is congenital thyroid agenesis, deformity or agenesis of the thyroid tissue from the infancy. So how we screen the patient or the community according to American Thyroid Association and American Association of Clinical Endocrinologists, measurement of the thyroid stimulating hormone. This is the common screening method for primary hypothyroidism. Personal history, if the patient had personal history of type 1 diabetes or other autoimmune disease, can be concomitant with hypothyroidism. If the patient has a family history of the thyroid disease, they should screen for thyroid hypothyroidism by doing TSH. History of the neck rehydration of the thyroid tissue. History of the thyroid surgery, so patient may be liable to hypothyroidism, and consideration measurement of TSH in patient over age of the 60, because it maybe came with the hypothyroidism. Treatment of the primary hypothyroidism, usually replacement of the thyroxine. The goal of the therapy is the restoration of the euthyroid state and decrease or elimination of the symptom, normalization of TSH secretion, avoidance of the over-treatment, atherogenic thyrotoxicosis. So the management is replacement of the deficiency of the deficient hormone. So the serum TSH within, we should keep the TSH within the normal level, which from 0.5 to 5, and some reference 4.2. And we can exceed this limit in the elderly patient. We can accept a level of 7.5 micro units per liter in patient in advanced age like 80 years of old. So the treatment of the chronic synthetic thyroxine by treatment is synthetic thyroxine called levothyroxine. It's very effective. It's easy and taken daily, and some patients we can give them weekly. Long-term benefit and cheapest medication, and there is ease administration, good intestinal absorption, long serum half-life. It may continue for 6 days. So if the patient misses 1 day, it can compensate the other day, and it's low cost, as I said before. There is another form of the thyroxine. If the patient cannot absorb, and patient with the absorption abnormality, like gastroparesis patient, there is form called gelatin-coated thyroxine. Can be used in patient with malabsorption or absorption abnormality. It's available in some countries, and a patient like patient post-bariatric surgery can use this gelatin-coated capsule to avoid malabsorption of thyroxine. And some patients, some formulation like intravenous thyroxine or intramuscular thyroxine, which can be used if the patient not tolerate oral feeding and not availability of the gelatin-coated thyroxine, or a patient not he is NPO and he cannot take orally. We can use the IP or parenteral thyroxine, and we can give 80% of the usual dose. What's the dose of the thyroxine, oral thyroxine? Usually we'll give patient, younger patient will give 1 to 1.6 microgram per kg body weight daily dose. We in the elderly patients, and especially in patients with ischemic heart disease, we start with low doses in 25 microgram up to 50 microgram, and we increase the daily basis. We can increase the dose every 2 weeks. So if the patient has history of coronary heart disease, or a patient elderly, we can upgrade the dose, or you can build up the dose every 2 weeks. We increase by 25 microgram. So what is the timing of the dose? We usually give the patient the thyroxine at morning, an empty stomach, and we let the patient eat. He can eat after 30 to 60 minutes to prevent any decrease of the absorption of the thyroxine, especially if the concomitant with the medication like iron or calcium tablet, it can decrease the absorption of thyroxine. So the patient should avoid eating after the thyroxine, after 30 minutes to 60 minutes after taking the thyroxine. And if the patient not taking at empty stomach, he can take after 3 hours after meal. He can take a thyroxine and avoid eating for 1 hour. So the initial monitoring of the thyroid function, usually we are measuring the TSH. Serum TSH should be measured after 4 to 6 weeks to look after the improvement of the TSH and thyroid function. So TSH is, we are monitoring it after 4 to 6 weeks. It's used to dose adjustment, and if the TSH more than reference range, we can increase the dose. And if the large changing in body weight, we can check the TSH, or a patient get pregnant, we can check TSH, because a patient pregnancy can cause more requirement of the thyroxine dose, and the patient needs more upgrading and increasing the dose. So factor increase requirement of the thyroxine. Pregnancy, as I said, weight gain. If the patient gain weight, he needs more thyroxine dose. If patient had more absorption, especially in celiac disease patient, and patient taking medication like ferrous sulfate, patient taking calcium, patient taking omeprazole, and a patient had autoimmune thyroiditis, he can use, or he can need more dose of the thyroxine. The dose of the 3T4 can be increased by 12 to 25 microgram daily in elderly and older patient, and or a higher dose in younger patients. So elderly, we should avoid to start high doses. We should build up the dose gradually. We start with the low doses, and we increase gradually every 2 weeks to reach the maximum tolerating dose and target TSH. Decrease thyroxine dose may be required in patient loss of weight. Patient needs to decrease the dose, or patient after delivery, a patient needs to decrease the dose, and if the patient initiate androgen therapy, or a patient get more advanced age. Adverse effect of the thyroxine therapy: excessive for thyroxine can cause osteoporosis, atrial fibrillation, inadequate L-thyroxine, inadequate levothyroxine, progression of cardiovascular disease, and determined affect serum lipid profile. Persistent elevation of TSH, it means the patient most common cause of high TSH while patient taking thyroxine, it's poor compliance. We saw a lot of patients, they are not taking their dose properly, that cause high TSH, and we should make the patient, we should ask a patient about compliance. If the patient not tolerate oral, daily oral, we can make the weekly dose of the thyroxine. We can calculate the dose of weekly, and we can give the patient weekly or twice weekly thyroxine dose, so a patient will tolerate this issue. And I have a lot of patients using weekly, they are tolerating weekly dose of thyroxine, and they are now in target TSH level. Patient had thyroxine malabsorption, usual patient with gastroparesis. I have patient with gastroparesis, the TSH was 800. So the patient compliant issue is very compliant with taking her medication regularly, but she had gastroparesis. This patient had malabsorption of the thyroxine, and if the patient had suspected malabsorption and using the dose more than 2 microgram per kg, patient suspected malabsorption, we should use loading dose of the thyroxine. We'll give weekly dose once, and we measure the thyroxine 3T4 after 2 hours. If the patient reach the dose, the level of the thyroxine 54% more than basal, patient is had usually compliance issue. If the patient had level less than 54% of the basal, patient had malabsorption issue. So persistent elevation of TSH due to autoimmune gastritis, celiac disease as malabsorption, intestinal bypass surgery, dose adjustment, increasing LT4 tablet doses, and gluten-free diet. This is the usually dose, and changing the thyroxine formulation to gelatin-coated thyroxine is very effective method in treating these patients. So, so in combination of the high TSH and normal high T4, if the patient has high TSH and high T4, this is differential diagnosis. There is two top differential diagnoses. It's called thyroid hormone resistant syndrome, or a patient has TSH screening pituitary adenoma. This patient, we should do MRI to identify any pituitary adenoma causing high TSH. So combination therapy of T3 and T4 therapy, is there any role? Some reference said there is some role, but there is the recommendation, there is no consistent strong evidence that this method is superior in combination therapy over the monotherapy with the levothyroxine. A therapeutic trial using doses of 3T4 and 3T3 that attempt to mimic normal physiology, ratio of T4 to T3, 13 to 1 or to 16 to 1, while maintaining a normal TSH is reasonable in selected patients. Candidates for combination therapy include patients who have not felt well with the T4 monotherapy since thyroidectomy, since ablation therapy with radioactive iodine. We have who have serum T3 at below the normal level and the T3 reference range. Monitoring and combination therapy by serum TSH measurement and 4 to 6 weeks after the combination therapy. In adults requiring thyroid hormone replacement treatment for primary hypothyroidism who feel unwell while taking levothyroxine, the question is combination treatment including levothyroxine and leothyronine superior to the use of the thyroxine alone. The recommendation for patients with primary hypothyroid who feel unwell, thyroxine therapy alone in the absence of an allergy to levothyroxine continue or abnormal serum thyroxine. There is currently insufficient evidence to support the routine use of trial of combination of 3T4 and T3. So, special population, elderly patients, we usually use the dose of, we start the patient with low dose of thyroxine, 25, and upgrading the dose up in the maximum tolerating dose up to 50, and we increase it to 25 every 2 weeks, and especially patient with coronary artery disease. Patient with coronary artery disease without their cardiopulmonary problem who have had recent successful intervention, we usually decrease the dose. We'll give the initial dose for 80% of the usual weight-based dose. Surgical patient usually will give not tolerate oral feeding, or they are NPO and they're taking thyroxine orally. Before the surgery, we'll give the parenteral thyroxine. We'll give 70 to 80% of the usual daily dose by IV route. If the patient thyroid cancer, higher thyroxine doses, usually used to suppress TSH because this is the therapeutic issue for thyroid cancer. I will concentrate now about the hypothyroid diet because the patient are overweight and the patient had decreased metabolism. Usually, patient advised to take low caloric diet to decrease carbohydrate to avoid weight gaining. Usually, we decrease the dose of the carbohydrate to 200 to 250 grams per day, and to lesser extent, we decrease the fat down to 80 grams, with 15% are vegetable fat. Usually, we avoid animal fat. To treat the impaired lipid metabolism and hypercholesterolemia, it's important to limit the food rich in the cholesterol. Animal fat should be avoided and decreased to avoid also increase weight. What are also the other consideration about the hypothyroid diet? Easily digestive carbohydrate, sugar, honey, jam, flour product. Patient should use for food rich in plant fiber, vegetable, unsweetened fruit, and vegetable usually advised, and patient advised to avoid high carbohydrate diet. It delay the absorption, the fiber diet delay the absorption of the carbohydrates and promote bowel evacuation due to the large volume, and plant fiber give sense of saturation and low energy value and help a patient to decrease weight. This diet is include food and dishes of moderately stimulate the gastric secretion and as well having laxative effects, namely vegetable, fruit, dried fruit, juice, vegetable oil, sour milk, and drink, brain goods. Hypothyroid diet also, a patient with the hypothyroidism need to receive sufficient amount of the iodine therapy, iodine through the alimentary tract. The leader in iodine content are seafood. Seafood is advisable for these patients. Seaweed and shrimps, mussels, carbs, and sea fish rich in the omega-3 fatty acid, salmon, pink salmon, and tuna. Ionized salts can advise for these patients. Seaweed is characterized by high iodine content, and sea fish. The hypothyroidism diet also, the optimum iodine intake is usually 150 microgram a day. Decrease in the dietary intake of the iodine less than 80 is dangerous, since it does not allow the maintaining the euthyroid state without stimulating the gland and forming its hyperplasia. So we should avoid a low iodine diet. We usually depend on the seafoods in this type of patient, and we can use iodinized salt for a patient with the hypothyroidism. This is a stimulating question for you. I want to see you replay. Which of the following would be most appropriate initial therapy in patient elderly 62 years patient woman has cardiomyopathy? Which doses of thyroxine advised? Yes, I think a lot of you chose the right answer. Right answer is C. 25 microgram daily is most appropriate for these patients, elderly and cardiomyopathy patients. You are right. 100% of you chose the right answer. So levothyroxine 25 microgram is advisable for these type of patients with elderly and cardiomyopathy to avoid any increased demand on the heart. Following the initiation of the thyroid replacement therapy, the most appropriate follow interval to determine the dose adjustment should be attended at 1 week, 2 weeks, 3 weeks, 4 weeks, or 6 weeks. Yes, I think 100 of you chose the E. E is right answer. 6 weeks usually interval to see the good replacement of the thyroxine. After 6 weeks, we'll see the TSH level. If it's high, we should increase the dose, especially in a patient with primary hypothyroidism. I want to thank you all for this attendance to my lecture, and I think we'll stop now for prayer, and we'll come inshallah at 8:30 inshallah to see to complete the lecture about the hypocalcemia inshallah. Any question before we leave for break, for prayer break? If you have question, you can go to Bismillah ar-Rahman ar-Rahim. Alhamdulillah wassalatu wassalamu ala Rasulillah wa ala alihi wa sahbihi ajma'in. Taqabbal Allah minna wa minkum salih al-a'mal. Welcome back for the lecture now about hypocalcemia. Hypocalcemia is defined as ionized calcium less than 4.5 milligram per deciliter and total calcium less than 8.5 milligram per deciliter. So the clinical manifestation of hypocalcemia, results from increased neuromuscular irritability and include muscular cramps, weakness, laryngeal spasm, and carbovidal spasm, paresthesia, and seizure-like activity. So twitching of the muscle, this is manifestation of hypocalcemia. There is a sign called cavestic sign, facial spasm produced by lightly tapping over the facial nerve just front of the ear, and trouser sign, there is carbovidal spasm which elicited by elevation of the blood pressure for 3 to 5 minutes above the systolic blood pressure. So it's elicit sign of trouser sign. I will show you the trouser sign and cavestic, then we'll back to the lecture. I will show you the video. I will stop sharing, then we'll go back to the lecture. I will show you the video.
RN.com, and in this video I'm going to talk about Trousseau sign. So let's get started. Trousseau sign is a a specific type of muscle spasm that occurs in the hand and wrist due to neuromuscular irritability, which tends to be a definitive sign of low calcium in the blood, hypocalcemia. It can also occur whenever a patient has a low magnesium level in the blood. Now, how do we assess for a Trousseau sign? Well, you're looking for either a positive or a negative sign. Positive meaning the patient has it, negative meaning they do not. So in order to do this, you need a manual blood pressure cuff, along with being aware of the patient's latest blood pressure reading. Specifically, you want to be aware of that systolic number of the blood pressure reading, which is the top number. Next, you want to place the blood pressure cuff on the arm and inflate this cuff to a pressure greater than the patient's systolic number and hold it there for about 3 minutes. Now, while you are holding it there, you want to look at that arm that has the blood pressure cuff on it, specifically that hand and wrist, and you want to monitor the reaction that is occurring on that side. If it is positive, the hand will draw in toward the body and flexion will occur at the wrist, thumb, and MCP joints, but the fingers will remain extended. And if nothing occurs during this, that means that it is a negative Trousseau sign. So why does this occur? Well, whenever we place a cuff on a patient's arm and we inflate it above their systolic blood pressure, we are occluding the brachial artery. And the brachial artery gives blood flow to the structures down here, like your forearm, your wrist, and your hands. Well, whenever a patient has a low calcium level, their nerves and muscles are already irritable and too excited. So whenever we impede that blood flow, hence cause ischemia, it's going to cause these structures down here to spasm. Okay, so that wraps up this review over Trousseau sign. And if you'd like to watch more review lectures, you can access the link in the YouTube description below. Registered nurse RN.com, and in this video I'm going to talk about Chvostek's sign. So let's get started. Chvostek's sign is a specific type of facial muscle twitching that occurs when cranial nerve 7, the facial nerve, is manually stimulated, and this demonstrates hyperexcitability of the facial nerve. It tends to be associated with patients who are experiencing hypocalcemia, so a low level of calcium in the blood, because many times these patients are experiencing irritability of their nerves and muscles. It can also be seen in patients who have a low magnesium level. So how do we assess for Chvostek's sign? Well, we're looking for either a positive sign or a negative sign. Positive means they have it, negative means they do not. So first, you want to identify the location of the masseter muscle on the patient, which is located at the jaw's angle. Next, you want to tap on this muscle and assess the response of the facial muscles on the side that was manually tapped. If it's positive, the facial muscles will contract momentarily. Example, the lips will twitch. If it's negative, no changes will occur. Okay, so that wraps up this review over Chvostek's sign. And if you'd like to watch more review lectures, you can access the link in the YouTube description below.
So we saw the Chvostek sign, tapping of the fish, the masseter muscle due to hypocalcemia, and through the sign there is carbopetus which shown in the video after the elevation of the blood pressure above the systolic. So albumin, we should measure the serum albumin because the calcium is connected the serum albumin. In patients with hypoalbuminemia, the serum calcium will show low level. So if you measure the calcium, you should measure the albumin, and you should calculate the ionized calcium or collected calcium to make sure the right level of the in serum alkalosis can precipitate hypocalcemia, and in serum acidosis there is precipitate hypercalcemia. Decrease in albumin, as I said, in patients with like nephrotic syndrome, it can show low level of the calcium. So we should measure the calcium and we'll calculate the correct calcium. Hypoproteinemia may lead to false suggestive hypocalcemia because serum total calcium level will low through the ionized calcium remain normal. So it's best to measure serum ionized calcium to make sure the right level of the calcium, or calculate the calcium corrected by albumin. Etiology of hypocalcemia, it's the most common cause of parathyroid hormone deficiency due to atherogenic removal of the parathyroid gland after thyroidectomy, or parathyroid hormone receptor defect, pseudo-hypoparathyroidism, or the mutation of DNA mutation of the parathyroid hormone, or there is magnesium deficiency. Exogenous inorganic phosphorus excess can cause hypocalcemia, and vitamin D deficiency can cause hypocalcemia. This is the major cause of hypocalcemia. Low patient with low VTH, it means hypoparathyroidism. There is deficiency of parathyroid hormone due to genetic causes or due to post-surgical after thyroidectomy or parathyroidectomy, or autoimmune disease. It's called hypoparathyroidism. It can be in the form of autoimmune polyglandular syndrome. Or due to vitamin D deficiency in patient with after surgery, and it's called hungry bone syndrome. A patient with high PTH, it means there is a parathyroid hormone, but it's high. It's called secondary hypoparathyroidism due to vitamin D deficiency. This is the most common cause of hypocalcemia with high PTH. And patient with multiple mutation of the PTH, hypomagnesemia, renal disease can be associated with secondary hypoparathyroidism, or tumor lysis syndrome, hyperphosphatemia, acute pancreatitis. Drugs that can cause hypocalcemia, which can cinecalcet, which is used to manage secondary hyperparathyroidism, or calcium chelating agents, citrate, phosphate, gadolinium-based contrast agent, phenytoin, anti-epileptic medication can cause hypocalcemia due to hypovitamin D. A disorder magnesium mechanism, hypomagnesemia can reduce the PTH secretion and cause PTH resistant, therefore associated with low PTH or high PTH with low calcium. So how we see or diagnose hypocalcemia? We'll see the serum phosphorus. If serum phosphorus high, serum calcium low, with PTH low, this is mean that patient has hypoparathyroidism. This is isolated autoimmune diseases or due to after surgery. This is with low PTH. If the patient has low phosphorus, it means phosphorus is hypophosphatemia, low calcium, high PTH. This is due to vitamin D, either vitamin D, 25 vitamin D, 25 vitamin D low with high vitamin 125 hydroxy vitamin D. It means vitamin D deficiency. If the vitamin D normal and 125 is high, it's called resistant vitamin D resistant rickets type 2, or a patient with the normal vitamin D with low 125 vitamin D, it's called vitamin D resistant rickets type 1. If the patient has high phosphorus, high PTH with low calcium, low urinary calcium. It causes secondary hyperthyroidism due to pseudo hypoparathyroidism due to patient with Albright osteodystrophy. It can cause by pseudo hypoparathyroidism type 1B and type 2, or a patient without Albright osteodystrophy with pseudo hypoparathyroidism type 1A and type 1C. This is a figure, or this is the table, shows the all feature and differentiation of the hypocalcemia. See, if the patient has low calcium, all they have low calcium, low calcium, high phosphorus with low parathyroid. We'll look for parathyroid. It's called hypoparathyroidism. Pseudo hypoparathyroidism, they have feature of hypoparathyroidism like low calcium with high phosphate, but the parathyroid is high. There is resistance. So if the patient has low calcium, high phosphate with high PTH, it's called pseudo hypoparathyroidism. If vitamin D deficiency, all calcium and phosphorus was low with high parathyroid, this is called secondary hyperparathyroidism with low vitamin D, 25 hydroxy vitamin D. Patient with familial hypophosphatemic rickets, low phosphorus, normal calcium with normal vitamin D. Hyperparathyroidism, high PTH with high calcium high PTH with low phosphorus. Immobilization can cause hypercalcemia with hyperphosphatemia. Embolization for high calcium, high phosphorus with low BTH. Hypocalcemia with low BTH, it causes hypoparathyroidism. This is common presentation autoimmune disease, autoimmune hypoparathyroidism, and also with post-surgical, as I said, post-thyroidectomy and post-parathyroidectomy as a secondary to surgery. Hypocalcemia with high PTH, there is a resistant or pseudo hypoparathyroidism. It's common presentation with low calcium, with high phosphorus, with high PTH. Hypocalcemia with high PTH, usually hypocalcemia with high PTH may be due to vitamin D deficiency, or with high phosphorus, it can be presented with chronic kidney disease. Hypocalcemia typically does not occur until the end stage of renal failure. Hypocalcemia with high PTH, PTH resistant, impaired PTH, pseudo hypoparathyroidism, which persisted in childhood. PTH resistant has also associated with recessive mission mutation, and the mutation of the PTH184 sequence, resulting in resistance to PTH because reduced PTH receptor binding to characterized by hypocalcemia, hyperphosphatemia, and depending on the assay used to measure PTH, either elevated or low normal concentration circulating PTH. Hypocalcemia with high PTH, hyperphosphatemia, acute renal failure. This include increased phosphate intake. Osteoblastic metastasis can cause high PTH, acute pancreatitis, sepsis. Surgery in patients who receive a large volume blood transfusion can cause occur during after major surgery in patients who don't receive transfusion. Disorder with magnesium metabolism, malabsorption chronic to the alcoholism, and cisplatin therapy are the most common cause of hypomagnesemia. Other include prolonged parenteral fluid administration, diuretic therapy, usually thiazide, can cause hypercalcemia, administration of aminoglycosides can cause hypocalcemia. Drugs. The most common drugs can cause hypocalcemia, bisphosphonate with treatment of the hypercalcemia or treatment of the osteoporosis can cause decreased bone resorptions and decrease the serum calcium. Denosumab, Prolia, which treatment of also hypercalcemia and osteoporosis can cause increase bone mineral density and can cause hypocalcemia. And if the patient starting this medication, we should measure and monitor the calcium and vitamin D. Senic acid, which also the treatment of the hyperthyroidism, and it can associated with hypocalcemia. Chemotherapy like cisplatin and fluorouracil and other medication can cause hypocalcemia. Treatment approach of the hypocalcemia of the patient depending on the symptom and sign of symptomatic of the hypocalcemia. If the patient had severity symptom with the paresthesia, carbopedia spasm, seizure, tetany, through the sign, capstic sign, bradycardia, impaired cardiac contractility, and prolonged QT interval depend upon the absolute level of calcium as well as the rate of decrease of the calcium. So the severity of the symptom and present of the sign of the hypocalcemia, it need the urgent intervention with the calcium. So the severe symptom of hypocalcemia, acute hypocalcemia, IP calcium is should be advised and will give first 2 ampulle of calcium gluconate to stabilize the heart. Then we'll give the maintenance dose of calcium as IV medication. Then we'll give vitamin D, calcium orally. Patient with symptom and also sign of hypocalcemia, capstic sign, Trousel sign, prolonged QT interval in the ECG, he needs and the calcium level less than corrected calcium less than 7.5. We'll give the IP calcium. We'll start with 2 gram. It's mean 2 ampulle of 10% calcium gluconate. We'll give it in 50 ml dextrose saline over 10 to 20 minutes. Slowly will stabilize the heart, and then we'll give the maintenance of calcium gluconate or calcium carbonate. We'll give 10 ampoules in 1 liter, and we'll run the fluid in 50 ml per hour to increase the calcium. So usually we'll give 11 grams, 10 ampoules or 11 ampoules and 1 liter in normal saline or dextrose water. We'll run it as 50 ml per hour, and we'll monitor the calcium, serum calcium with albumin every 4 hours till we reach the target calcium. In the meanwhile, we'll give also vitamin D and 1 alpha. We'll give usually 1 alpha, and 1 alpha it's fast active vitamin D, and the half-life reach after 3 days. After we monitor daily until the patient reach the normal level of the calcium and no symptom. Then we'll stop the infusion and we'll measure the calcium after 2 hours of the infusion of the calcium, and we'll see the calcium. If the calcium is stable, that time we'll stop the IV calcium. In the meanwhile, also we can give oral calcium, 600 milligram BD or TID, calcium carbonate orally to overcome the hypocalcemia. If the also the we check, we don't forget to check the magnesium. Magnesium will cause hypocalcemia, and because it's a cofactor of the VTH parathyroid hormone. Well, if the potassium, magnesium is low, will replace magnesium with giving 1 gram over in 100 ml fluid per hour. We will give 2 gram and you'll see the level of the magnesium. Patient with mild symptom, calcium from 7.5 to 8. We'll give patient orally. Such patients typically asymptomatic or most mildly symptomatic. Oral procedure, they can treat it initially with 2 gram elemental calcium given a calcium carbonate, calcium citrate daily orally, plus also the high vitamin D. Mildly symptomatic chronic hypocalcemia, for such patients with mild degree of acute hypocalcemia, mild symptom, who don't have symptomatic improvement with oral calcium, patient will switch it to IV calcium, and the IV calcium also indicated prevent acute hypocalcemia in patients with mild degree hypocalcemia and chronic hypocalcemia. What about the mild symptom of chronic hypocalcememia? In addition to calcium, patient needs vitamin D. Will give usually active vitamin D1 alpha. Prevention of hypocalcemia after total thyroidectomy, because we should concentrate on this issue. A lot of patients going for removal of the thyroid gland due to malignancy or due to large goiter, they go for hypocalcemia due to maybe ischemia of the parathyroid or removal of the parathyroid gland. So hypocalcemia is most common complication of thyroidectomy procedure. It's involved, can happen after surgery. It's 4% of the patients can prolong it to 6-12 months after the surgery. Study adult reported incident of hypocalcemia in USA about 1 to 50%, with the most center around 20 to 30. Contrast, pediatric study found that 30 to 40% of the children developed parathyroid dysfunction after the total thyroidectomy. The majority transient. The nadir for the hypocalcemia usually occur 24 to 48 hours after the post-surgery, and may occur early after 12 hours post-surgery, post-operative, or delay to 4 days. A pathway for the preoperative assessment and management of patients undergoing total thyroidectomy. Usually in preoperative, we'll check the calcium and albumin and vitamin D level for surgery. We give stress dose of vitamin D around 150,000 international units of serum, if serum 25 hydroxy vitamin D less than 15 nanomole per liter, to prevent any hypocalcemia after surgery. Surgical team informed and inpatient endocrinology team also should be informed. Intraoperative management usually will measure the intraoperative parathyroid hormone, can also indicate higher risk for parathyroid post-thyroidectomy hypocalcemia. Usually, in patients suspected removal of hypothyroid parathyroid gland or parathyroid ischemia, we should measure the active VTH. However, post-operative VTH level may be helpful in patient guiding management of patients who developed hypocalcemia. Post-operative serum calcium should do it, and also albumin to correct the calcium and to discover any hypocalcemia, and also VTH level should be performed 6 hours post-operative. VTH, if the VTH more than 2.1 biomole per liter, a normal calcemic patient is usually reassuring. VTH less than 1.6 millimole per liter is associated with high risk of hypoparathyroidism and require more intensive monitoring and slower wean supplement. Prophylactic calcium and calcitirol replacements should be started orally once the patient is able to tolerate and initiate oral feeding after 12 hours post-operative. Routine post-operative prophylactic replacement of calcium with or without calciferol, يعني active vitamin D, has been shown to reduce post-thyroidectomy hypocalcemia. Prophylactic calcitirol, vitamin D, active vitamin D, should be given in patients with high risk, like vitamin D deficiency. Prophylactic calcium only to those patients with low risk. High-risk patient, those patients meets the criteria for one of the following: parathyroidectomy, parathyroid tissue damage, devascularization, patient with lymph node and central dissection of the neck, hyperthyroidism, patient with younger than 6 years of age. If patient with high-risk patient developed biochemical hypocalcemia, total calcium less than 2 millimole or 8 milligram per deciliter, or isoniazid calcium less than 0.9 millimole, starting the dose of calcitirol 0.025 microgram to 5 microgram to 0.5 microgram per kg should be given post-operatively as soon as possible, in addition to oral calcium carbonate as detailed. Calcium level should be checked again after 12 hours post-operatively. If total calcium remain more than 2 millimole, then the patient can be discharged safely to home. And once the surgical team has cleared the patient, if the patient is discharged, serum calcium level should be rechecked after 2 to 3 days after discharge. Patient who developed hypocalcemia and patient who developed symptom of hypocalcemia, mild muscle cramps, muscle spasm, and fatigue, severe tetany, seizure, laryngospasm, arrhythmias, prolonged QT interval, serum calcium management, magnesium level should be checked immediately. Treatment where high-risk patients should comment and as soon as possible, calcium and calcitirol, active vitamin D, may be increased if a patient develops hypocalcemia, while a calcitirol treatment. Intravenous calcium is indicated in patients with symptomatic hypocalcemia. Continuous infusion calcium deposits may occur after extravasation, so the cautious and IV treatment of the calcium should be taken into consideration. Care must be given to the intravenous site, ensure free flowing period during administration of the calcium. Suggestive IV calcium doses: IV calcium 10% calcium gluconate, 0.5 ml per kg, given diluted solution slowly over 20 to 60 minutes. IV infusion 10% calcium gluconate solution, 4.5 ml per kg. Continuous infusion, usually using the infusion pump. Discharge can be considered if the symptom of hypocalcemia is resolved and total calcium level are more than 2 for 3 consecutive checks. As required, BRN calcium, calcitriol order, those where high risk guidance above is where the age weight guidelines should be charged, and calcitriol is available on the world. Should be a patient developed patient with hypocalcemia. So the advice is given in patient with symptomatic hypocalcemia, given calcium gluconate start to stabilize the heart, 2 ampule slowly, 20 to 30 minutes. After this start infusion, we start the maintenance dose of giving the 11 ampules of the calcium gluconate 10% and 1 liter normal saline or dextrose saline or dextrose water, and we'll give it the infusion 50 ml per hour, and we'll monitor the calcium after 4 hours. If the patient developed normal calcemia and 3 readings normal, we'll stop the infusion and we'll check the calcium after 2 hours of stopping the infusion. If the calcium go down, we resume the infusion. Don't forget to give the patient active vitamin D and 1-alpha calcitriol to stabilize the calcium and to stabilize the calcium, and take the consideration the half-life of calcitriol 3 days. So the reaching the steady state of the calcium usually takes 1 to 2 days to stabilize and retain the calcium to normal level. And a patient can give given oral calcium, and if the patient is stable, we can discharge the patient. So a follow-up usually after patient discharged with 2 to 3 days, we'll check the calcium albumin to make sure that all things is on right pathway. For a low-risk patient, we'll check the calcium level weekly. If the calcium remain within normal calcium dose weekly until reach the calcium carbonate 600 daily, then we can stop the calcium if the serum calcium level is normal for 1 week after. Patient who developed hypocalcemia required calcium, calcitriol doses beyond the above suggested guidance. Ongoing discharge planning should be individualized as a patient and patient by endocrinology team. PTH testing with timely turnover is not available in many centers and is therefore not likely to guide immediate treatment. However, once available, it can guide the future management. PTH more than 2 bimole is a normal calcium patient is reassuring. So low PTH should mean patient is still hypoparathyroidism. This is the cause of the hypocalcemia, and patient needs calcium and vitamin D. Maybe it's transient and we should monitor the calcium. If the patient normalized calcium, maybe the PTH, we repeat the PTH after some time to make sure the patient had normal PTH and normal calcium. High-risk patient after the parathyroidectomy who removed the parathyroid tissue, or patient going for devascularization or neck dissection. Calcium dose, as we know, elemental calcium 50 to 150 milligram per kg in divided doses in adults. Symptoms of hypocalcemia include muscle spasm, cramps, numbness, and tingling. We should measure the calcium, vitamin D, and parathyroid hormone, and albumin. So this is how we initial management of the hypocalcemia in adults without chronic kidney disease. Usually, patient symptomatic. If the patient has symptomatic, we'll give IV calcium. If the patient start, then we'll measure the calcium, albumin, parathyroid hormone, and vitamin D. and patient needs maintenance dose of calcium. If symptomatic, still will give IV calcium maintenance and calcium. If the patient is asymptomatic, usually with low calcium, we'll give oral calcium. If the patient has calcium, serum calcium more than 7.5, will able to take calcium, will give oral calcium. If the patient is asymptomatic with mild symptom, we give oral. So if the patient is symptomatic, give IV, or patient less than 7.5 calcium will give IV calcium. I want to thank you, and if you have any question before we conclude. Okay, because no question, I want to thank you, and inshallah we'll see you in the next lecture or next course. Thank you, Allah.